Audible and visible?
Yes, please start.
Sir, my study is good afternoon, one and also. My study is about clinical and radiological study of unsafe CSOM. Myself, Dr. Tigala Udaikiran Reddy, and atticoantral disease is traditionally diagnosed by otoscopic examination and treated by explorative surgery. The need for imaging in an uncomplicated case is contentious. This study assesses the role of HRCT temporal bone study in patients with CSOM of squamosal type. Unsafe CSOM, cholesteatoma, and granulation is classically recognized by posterior superior marginal tympanic membrane perforation involving Parkes flaccida on otoscopic examination. This may also show retractions in posterior superior tympanic membrane, which may involve annulus posterior superiorly. The presence of cholesteatoma must be suspected beneath the polyps protruding from Parkes flaccida or when there is marginal tympanic membrane granulation. Cholesteatoma is potentially a serious condition as it can progressively enlarge and erode into neighboring structures, give rise to serious extracranial and intracranial complications. Barring any medical contraindications, treatment of a suspected cholesteatoma is by surgical exploration and eradication of the disease with tympanomastoidectomy operation. Unlike the situation with endoscopic sinus surgery, whereby routine preoperative HRCT scan is widely used as standard practice, the need for preoperative HRCT scan is controversial. Even among the experienced otologists, there is no single accepted standard for the need of HRCT scan in uncomplicated cases. The advent of HRCT has brought the significant enhancement in the preoperative assessment of temporal bone pathology and fine anatomical debris. The intent of this study is to evaluate the accuracy and the usefulness of HRCT as imaging modality in our patients with CSOM of squamosal type. HRCT provides excellent detail of bony landmarks within temporal bone due to inherent contrast as its dense bone being surrounded by air of tympanic cavity and mastoid air cells. It has also added a whole new dimension to imaging of temporal bone by allowing visualization of soft tissues components within and adjacent to the temporal bone. Therefore, one of its major contribution to the otologists dealing with the disease is the preoperative localization of cholesteatoma sac with HRCT, a detail that not only determine the type of surgical approach, but also alert the surgeon to possible intraoperative and postoperative complications. The objective of my study is to find clinical findings, HRCT temporal bone scans, and surgical findings in the cases of cholesteatoma. Materials and methods. This is a prospective study of 20 cases of CSOM squamosal type of disease attending the OPD of our hospital, and we did the examination with the otoscope and endoscope to confirm that they are of squamosal pathology. Then patients underwent HRCT of temporal bone, findings noted and recorded. During the surgical procedure, intraoperative findings are noted and compared with radiological findings. Inclusion criteria: cholesteatoma that are detected clinically, marginal tympanic membrane perforation, posterior superior retraction pocket with granulation, history of scanty purulent blood-stained discharge with foul smell, and exclusion criteria: patients who undergone previous surgeries and tubotympanic cases. Results. Out of my 20 cases, the gender distribution is as follows, like 12 male and 8 female. And age-wise distribution is as shown. The most of the cases are found between 11 to 20 years. You can see here, and next are 21 to 30 years, which are 30 and 20% respectively. And HRCT findings versus surgical findings. In ossicular erosion, there are 12 ossicular erosion cases we are found in HRCT, and intraoperatively there are 13. Facial canal dehiscence, there are 4 cases in HRCT and 3 intraoperatively. And lateral semicircular canal erosions are found in 1 case in HRCT and respective case in intraoperative identification. Tegmen erosion, there are 11 cases in HRCT and 10 cases intraoperatively. This is axial HRCT image showing the tissue density mass in left medullary cavity and with the erosion of medullary cavity Otitis antrum with erosion of sigmoid sinus plate and lateral cortical wall of mastoid, and mastoid septae are eroded, forming a single cavity on left side. This is intraoperative modified radical mastectomy image of an in case of cholesteatoma showing mastoid antrum after drilling. This is endoscopic image of postoperative year after MRM with Tympanoplasty in patient of 9 years with cholesteatoma. Discussion. Presence of cholesteatoma is seen in clinical examination as the posterior superior tympanic membrane perforation, retraction pockets and granulation confirmed in HRCT scan as soft tissue density mass and is seen in 20 cases who had attended the tertiary care hospital. Out of 20 patients, males are 12 and females are 8. Males are in preponderance with 1:5 to 1 ratio. And gender distribution corresponds of my study corresponds to Tukral CL and associates and reported a male to female ratio of 1.38 to 1, and Pausdek and Ital reported a male to female ratio of 1.39 to 1. Age distribution is highest in 11 to 20 years with 30% of cases and is in correlation with Ramandeep et al. Study. Ossicular erosion found in 12 cases radiologically and intraoperatively 13 cases. Facial canal erosion in 4 cases, but intraoperatively 3 cases are confirmed. Lateral semicircular erosion is found in 1 case radiologically and corresponding case intraoperatively. Tegmen erosion found in 11 cases radiologically and 10 cases intraoperatively. Above study showing 92% of sensitivity in finding ossicular erosion in HRCT temporal bone, 100% for lateral semicircular canal erosion, and tegmen erosion sensitivity with 91%. This corresponds to study of Mandal S and et al. Ossicular erosions of malleus showing sensitivity of 91% approximately, and incus 93 and stapes 78% were detected, and erosion of scutum 94%, tegmen 67%, facial nerve canal 75%, and semicircular canal fistula 80% sensitivity. And conclusion is like a pre-surgical evaluation of cases of atticoantral disease with HRCT temporal bone, and it benefits the patient and surgeon is armed with the visual aid for preoperative counseling, extent of the disease, and identifies the areas of problems prior to the operation. These are my references, sir. Thank you, sir.
Dr. Uday Kiran Reddy, can you hear me?
Yes, ma'am.
Let's do it as a study because we are already following it up. Why did you choose this topic?
I just want even more effective or like the cases we are studying here.
That it is definitely useful.
Yeah, yes, ma'am.
Was it a retrospective study or prospective
No, ma'am.
study?
It's a prospective study, ma'am.
Okay. How did you calculate your sample size? It is only 20 cases.
20 cases, ma'am. I calculated the prevalence of this area, ma'am. Like I found the prevalence, and I calculated the prevalence, and so in 1 year we got like in 1.5 year previously 1.5 year we got all these cases, and they got operated, ma'am. Here.
With this study.
The development means, ma'am, like how we can because this is in rural areas we cannot write the diagnostics as we wish. So when there is definitive indication and when it helps us for writing them, and how the different structures of medullary are affected. So I found them, ma'am, in this study.
Okay. Sir, any more questions? I'm done with my questions.
Next presenter, Dr. Sai Priya.
So can I leave, sir?
Yeah.
Rohit, sorry to interrupt.
Sir.
Rohit, am I audible?
Yes, sir. Audible.
Thank you, Nagaraj sir. Welcome to our AOITSCON virtual session and Chitra madam. Thank you so much, ma'am. Because of technical issues, I did not be on online during that time, sir. I got one small request, sir.
Yes, sir.
Sir, this is a case series session, sir. The maximum time limit is 8 minutes
Yes.
for the first type of presentation, sir. If they finish within 8 minutes only, they will take the question. So our coordinators will give a bell, sir, at the time. First bell at 7th minute and second bell after finishing 8 minutes, sir. If they finish within the time only, you ask the question, sir, my request. Thank you so much, sir. Thank you, ma'am.
Yeah, sure, sir.
Yeah. Please, Rohit, go ahead.
Yes. You can start your presentation.
Eagle syndrome is a rare condition is due to elongation of styloid process or calcification of stylohyoid ligament characterized by craniofacial or cervical pain. The symptoms related to this condition can be confused with those attributed to a wide variety of facial neuralgias, oral, dental, and temporomandibular diseases. Radiological imaging helps in identifying the elongated styloid process. The treatment of Eagle syndrome mostly is primarily surgical. The styloid process can be shortened through an intraoral or external approach. In this paper, cases of Eagle syndrome exhibiting unilateral symptoms with elongation of styloid process shortened through intraoral approach has been reported. Anatomy of styloid process. Normally, styloid process originates as a part of Richard's cartilage from the second pharyngeal arch. The styloid process is a cylindrical, slender needle-like projection from the inferior part of petrous temporal bone, lying inferior and anterior to external auditory meatus, and anterior medial to mastoid process, and anterior to stylomastoid foramen. Richard's cartilage, which divides into 4 parts: tympanohyal, stylohyal, ceratohyal, and hypohyal. Tympanohyal attaches to petrous part and gives rise to the base of styloid process. Stylohyal, which gives rise to shaft of styloid process and proximal part of stylohyoid ligament. Ceratohyal gives rise to styloid ligament, and hypohyal lesser cornea of hyoid bone. The stylohyal fuses with tympanohyal after puberty. Then the styloid process is divided into 2 segments, proximal and distal segments. Proximal segments, which gives rise to vaginal process of tympanic portion of temporal bone. Distal segment has shaft and stylohyoid muscle, and stylopharyngeus muscle and styloglossus muscle. Next, the styloid process apex origin of 2 ligaments: stylohyoid ligament, which attaches to lesser cornea of hyoid bone; stylomandibular ligament, ramus of mandible. These muscles and ligaments helps to facilitate the movement of tongue, pharynx, larynx, hyoid bone, mandible, and mandible. The blood and nerve supplies of vessels and nerves which are medial to styloid process are internal jugular vein, internal carotid artery and its branches like lingual artery, facial artery, superficial temporal artery, and maxillary artery. And then the nerves are glossopharyngeal nerve, vagus nerve, spinal accessory nerve. And the vessels which are lateral to styloid process are external carotid artery and its branches occipital artery, and the facial nerve, hypoglossal nerve. The styloid process length ranges from 5 mm to 50 mm. The normal length of styloid process ranges from 25 to 30 mm. Styloid process is considered to be elongated when it is longer than 30 mm. The elongated styloid process and the ossified stylohyoid ligament can compress the structures in close vicinity, leading to symptoms like sore throat, dysphagia, referred otolgia, foreign body sensation in throat, facial pain radiating to ear or along the mandible, head and neck. This anomaly appears in adults with varying frequency ranging from 2 to 30%. Here, this is a case series of elongated styloid process with symptom presenting to otolaryngology OPD in our hospital. All the cases presented with history of pain and foreign body sensation in throat, which of them 2 were females and 1 is male patient. They were visited to private practitioners but not relieved with antibiotics and analgesics. General physical examination of patients was normal, and otolaryngological examination of ear and nose were normal. Examination of oropharynx revealed a chronic tonsillitis in all the cases. On digital palpation, a sharp prick or bony hard projection was felt and the tonsillar fossa, which is unilaterally. Clinical diagnosis of elongated styloid process was confirmed. Plain X-ray, cervical spine, lateral view, and orthopantogram was done. CT scan was done, skull base, for confirming the diagnosis. The patient were diagnosed as elongated styloid process. Patient surgical profile was normal. Patients underwent bilateral tonsillectomy with intraoral styloidectomy under general anesthesia. Here is an orthopantogram of patient showing a right elongated styloid process, and the cervical spine X-ray which shows elongated styloid process, and then CT scan. After the tonsillectomy by dissection and snare method, elongation of styloid process has been palpated in the tonsillar fossa. The tip of elongated styloid process was dissected, stripped off all the attachments and nibbled off using a bony nibbler. All the patients were discharged within 4 to 7 days, prescribing with antibiotics and anti-inflammatory drugs. Here the patients with symptoms presenting are mostly unilaterally of age 30 to 50 years, of 36 mm, 33 mm and 34 mm of elongation of styloid process. And all the patients presented with pain in throat and foreign body sensation and referred otalgia and some headache, no palpable neck muscles, and one patient has a history of trauma. The association of cervical facial pain and other symptoms with an elongated styloid process was described by Eagle in a pair of case reports in 1937. This association is now known as Eagle syndrome. Subsequent investigations by Eagle are divided into two groups with different etiologies. The first of these is the classical Eagle syndrome. The second is carotid type. Classical Eagle syndrome is typically seen in patients after tonsillectomy, though it can occur in patients without history of pharyngeal surgery. The patient generally present with ipsilateral cervicofacial pain, often centered on angle of mandible, which may be referred to the ear, and exacerbated on the rotation of head. Symptoms frequently include dysphagia, foreign body sensation in throat, otalgia. The clinical symptoms which the patient presents is due to compression of adjacent nerves in close proximity to styloid process, mainly lower branch of trigeminal glossopharyngeal facial. The appearance of these impingement following tonsillectomy minor trauma has been hypothesized due to one or more number of cases. Entrapment of granulation tissue following surgery, minor trauma, direct irritation in tip of elongated styloid process, and fracture of styloid ligament due to sudden head movement, non-union degenerative changes affecting the insertion of styloid ligament, leading to insertion tendinosis. The second form is carotid type, which is impingement of internal and external carotid artery by laterally or medially deviated styloid process. This may be accompanied by referred pain along the distribution of artery, causing stimulation of sympathetic nerve plexus. In the case of impingement of internal carotid artery, referred along the course includes eye pain as well as parietal headache. The patient may be diagnosed with cluster headache, migraine. Eagle syndrome is diagnosed by both radiological and physical examination. Styloid process palpation in tonsillar fossa indicative of styloid process which is not normally palpable, elongated styloid process, can be treated conservatively and surgically. The most satisfactory and effective treatment is surgical shortening of styloid process through either intraoral and external approach. Eagle initially described stylohyoid ligament by intraoral route, where the transpharyngeal approach was used to extract styloid process after tonsillectomy. There is no external scarring with this approach and low postoperative morbidity and complications. Styloidectomy can be performed by external approach through an insertion through extents from the mastoid process along the sternocleidomastoid to the level of hyoid bone and then up to across the midline of neck to the midline of chin. This approach is aesthetically less pleasing with more morbidity compared to intraoral route. The reported cases are successfully treated using intraoral approach. My conclusion is about Eagle syndrome associated with elongated styloid process is rare condition. Clinical palpation of tonsillar fossa was complemented with an X-ray and CT scan to make confirmative diagnosis. The length of styloid process correlates with clinical symptoms and signs. Tonsillostyloidectomy is a treatment of choice in all the cases of Eagle syndrome, has definitely proven to relieve the patients of styalgia. Awareness of this syndrome is important to all the otorhinolaryngologists involved in the diagnosis and treatment. These are my references, sir. Thank you, sir.
Doctor, can you hear me? Control it. What is the accepted incidence of Eagle syndrome in general population?
Incidence of Eagle syndrome in general population is mostly 4% of general population of Eagle syndrome.
Yeah. How did you
Population
actually, what made you suspect elongated stay?
Patient, some patients has one patient has history of trauma which unable to open the oral cavity while for chewing the food. And-
Okay.
and
Okay.
You said in 3 cases, what was the usual length of the stylohyoid ligament?
The
Knowledge.
one patient has 36 mm and one patient has 33 mm and one patient has 34 mm of elongation, sir.
So to get a symptom, so what should be the ideal length to get a symptoms for the patient? Do you have any idea regarding that?
Sir, I can't understand, sir. Can you repeat, sir, please?
Yeah, you said around 33, 36 and another 32 millimeters, right?
Yeah. No, sir, I
Oh.
can't hear you, sir. Can you repeat, sir?
Okay. Am I audible now? Hello?
Yeah, sir. Yes, sir. Yes, sir.
Okay, so you said all the 3 cases, it was
Yes, sir.
both radiologically as well as CT showed the same millimeters?
Yes, sir.
Okay, fine.
Thank you, sir.
Presenter Jhansi Lakshmi, Dr. Jhansi Lakshmi. Rakesh, can you hear my voice?
Yeah. Rohit?
Are you hearing bell sound? Bell sound?
No, I can't hear any bell sound.
Go ahead, Jhansi Lakshmi.
7 minutes, 1 minute left, like that. After completing
Okay,
8
okay,
minutes, you can say time up. Okay?
Yeah. Okay, sir. Fine.
Yeah, go ahead.
Yeah.
Dr. Jhansi Lakshmi, share your screen.
Yeah, sir. One minute, sir.
Sir, if there is any problem with the sharing screen, we'll go ahead with the
Next presenter.
Doctor.
Dr. M. Tanusvi from MNR Medical College, are you available?
Yes, sir.
Yeah, you can start your screen sharing.
Sir, can I tell next to the person, sir? There is some technical problem. My
Yeah, we'll get back to you.
my PPT is not opening, sir.
Yeah. Let Dr. Tanusvi present.
Good evening, everyone. I'm Dr. Tanusvi. Today I'm going to discuss about
Hello, sir.
microbiological study of.
You continue.
So, can I
Continue.
continue? So I'm going to discuss about microbiological study of otitis externa, a case series. Otitis externa or external otitis is a condition of the skin of the external auditory canal, which is characterized by edema and erythema associated with itchy discomfort and usually an ear discharge. It is an inflammatory, typically infectious disorder of the external ear canal. Otitis externa generally affects about 3 to 10% of total population. The predisposing factors of otitis externa includes anatomical obstructions such as impacted cerumen, exostosis, external ear stenosis, or it may be due to physiological factors such as immunocompromised state or humidity, or it may be due to traumatic like repeated ear probing or ear laceration, or it may be due to allergic and other microbiological factors. Otitis externa occurs because the protective lipid acid balance of the ear is lost. The initiating event in bacterial otitis externa is believed to be an abrogation of the hydrophobic ceruminous coating of the external canal, which exposes the underlying epithelium to water and other contaminants, which leads to edema and excoriation of the epithelium. These violations of the epithelium allow for bacterial infection. The most common bacterial pathogens causing otitis externa are Pseudomonas aeruginosa and Staphylococcus aureus. Otomycosis is a fungal infection of the external auditory canal. Fungal infections are considered as opportunistic infections, and mostly they are secondary to bacterial infection. Aspergillus niger and Candida are the most common fungi causing otomycosis. Aims and objectives. It is to study the various type of otitis externa and commonest modes of presentation, to determine the causative agents of otitis externa, to study the antimicrobiological susceptibility pattern of bacterial isolates. Materials and methods used. It is a prospective study carried out in the Department of ENT during the period of March 2023 to July 2023. A total of 30 patients were included in the study. Coming to exclusion criteria, patients with previous ear surgeries, otomycosis cases with fungal infection elsewhere in the body, suspected malignancies, and infiltrating tumor were excluded. Inclusion criteria. Cases with following symptoms were included in the study: severe itching in the ear, pain in the ear, sensation of sound in the ear, sense of blocked ear, impaired hearing, discharge from the ear were included. All age groups were included in the study. The first picture shows is a normal tympanic membrane, which is usually pearly gray in color and translucent. And this second picture shows diffuse otitis externa. We can see the entire external meatal skin is edematous. Whereas the last picture is the chronic otitis externa, where usually the discharge is scanty and it presents as dried up flakes. This picture shows it is an otomycosis. We can see black color spores in the external auditory canal along with some debris. And this is the localized otitis externa, which is also called as furunculosis. Methods of collection of data. Each patient was subjected to detailed history taking and examination. The examination of auricles and external auditory meatus of these patients was done with an otoscope. 3 ear swabs were collected from the affected ear by examination of the auricles and external auditory canal with the help of bullseye lamp. Coming to results and observation, table 1 shows the symptoms among study group. The most common presenting symptom is pain. About 73.3% of the study of the cases showed pain as the main presenting complaint, and 53.3% of cases showed ear discharge as the main complaint, and 50% showed itching, followed by 46.6% showed blockage as the presenting complaint. This is an histogram showing the symptom distribution. We can see the most common presenting symptom is pain, followed by ear discharge, followed by itching and blockage. This table 2 shows the microscopic evidence among the study group. 50% of the cases are KH positive. 23.3% are positive for both KH and gram positive. 20% are KH negative and gram positive, whereas 6.6% are negative for both KOH and gram staining. The most common culture among study group is fungal culture. 53.3% of cases showed fungal growth, whereas 26.6% of cases showed bacterial growth and 16.6% showed mixed growth, whereas 3.3% showed low growth in the culture. These are the various fungal isolates. The most common fungus to be isolated is Aspergillus niger, and it is seen in about 47.6% of study of cases. It is followed by Candida species, which is seen in among 23.8% of cases. It is followed by Aspergillus flavus, seen in 19.04% cases, and Aspergillus fumigatus seen in 9.52% of cases. This figure shows a distribution of fungal isolates in a pie diagram. We can see Aspergillus niger is the most common fungal to be isolated. It accounts for about 48%, followed by Candida, followed by flavus and fumigators. Bacterial isolates in study group. The most common bacteria isolated in this study is Staphylococcus aureus, which is seen in among 53.84% of cases. It is followed by Pseudomonas species, which is seen in about 23.07% of cases. Coagulus negative Staphylococcus is seen in 15.38% cases and followed by Klebsiella, which is seen in 70.6%. This again shows distribution of bacterial isolates.
1 minute more.
This slide shows antibiotic sensitivity among bacterial isolates in the study group. Staphylococcus aureus is sensitive for amexiclav, cephalosporins, fluoroquinolones, aminoglycosides, and carbapenems. Pseudomonas species is sensitive for cephalosporins, fluoroquinolones, aminoglycosides, and carbapenems. Coagulus negative Staphylococcus is sensitive for amexiclav, cephalosporins, fluoroquinolones, aminoglycosides, and carbapenems. Klebsiella is sensitive for cephalosporins and carbapenems. Conclusion: otitis externa is one of the most common conditions seen in the otolaryngology clinics, affecting 3 to 10% of total population. In our area, pain was observed in more number of cases than itching and discharge. And Aspergillus niger and Candida species were the commonest fungi, whereas Staphylococcus aureus is the commonest bacteria isolated in the otomycosis cases. These are my references. Thank you, everyone. Thank you, sir.
Can I present?
Thank you.
Thank you, ma'am.
Hello, sir and ma'am. This is Jansi. Can I present,
Yeah.
ma'am?
Yeah, you present.
Yeah.
Jansi Lakshmi, are you
Yes,
able to share the
sir.
screen? If not, we'll
Yes.
proceed. You can present at the end.
Yes, sir. My PPT is not opening, sir.
Yeah, we'll go ahead with the next.
That's why we have conducted practice sessions.
Straight has opened.
Okay, next candidate, please.
Yesterday it has opened, sir.
Next candidate, Dr. Ravali Chandragiri from Mallareddy College.
Good afternoon, sir. Good afternoon, everyone. Can I
present
proceed,
with the
sir?
virtual
Yeah,
screen,
yeah.
ma'am. Most of
Share
the
your screen.
candidates
Share your
are
screen,
go ahead.
ma'am.
Go ahead.
Yes, sir.
For all the candidates, they have to present with the virtual screen of AOI Telangana DSCON.
Change your backgrounds to virtual screen from AOITSCON Miralgura.
Okay, sir.
Go ahead. Go ahead. Please share your screen. We are seeing you, but the screen is not here.
Yes, sir. Sir, there's something wrong, sir. I'm unable to share the screen, sir.
With next candidate.
Yeah. Dr. Sriharsha.
Yes, sir.
Yeah. Kindly share your screen.
Okay. It is visible, sir.
Yeah. Go ahead.
Yeah. Good afternoon, all. Myself, Dr. Sriharsha. Today, I'm going to discuss about a case series on intraoperative assessment of hydrogen peroxide versus normal saline as a hemostatic agent in tonsillectomy bleed. Coming to introduction, alternate tonsils are components of immune system. These are immunologically more active in first years of life. After multiple episodes of infection, bacteria inoculated into the core of the tonsil and producing symptoms like sore throat, dysphagia, fever. This infection is highly frequent, especially in childhood. Although antibiotic therapy is usually sufficient for acute tonsillitis, but in chronic tonsillitis and recurrent tonsillitis, tonsillectomy is the treatment of choice. Despite the tonsillectomy is the simplest and commonest surgery, the surgeons keep an eye on high-risk complications of tonsillectomy, like intra and post-operative hemorrhage, which may even lead to shock and death. Coming to aims and objectives, the aim of the study is to compare the efficacy of hydrogen peroxide as a hemostatic agent in tonsillectomy bleed as compared to the normal saline. The objective is to draw correlations between the two groups. Hydrogen peroxide produced in many different human cell types like fibroblasts, vascular smooth muscle cells, and inflammatory cells. It plays a key role in regulating vascular smooth muscle cell growth and differentiation. When delivering the hydrogen peroxide into the wounds, it kills the fibroblast and occludes local microvasculature. When hydrogen peroxide dissociates, it forms water and nascent oxygen. This nascent oxygen has oxidative properties and thus it helps in achieving surface antimicrobial clearance. Apart from that, various mechanisms of hydrogen peroxide include it increases the calcium influx from the intracellular smooth muscle cells, leading to formation of cyclooxygenase derived postamides and activation of enzymes and potassium channels, further leading to formation of hydroxy free radicals. So the types of bleed in tonsillectomy are venous bleed and mucosal bleed. Generally, local pressure given with a cotton ball soaked in NS, but in our study, we have cotton ball soaked in 3% hydrogen peroxide to apply the in fossa from dissection to achieve hemostasis. The amount of blood loss and time taken from incision to hemostasis are the parameter in our study. Coming to materials and methods, the sample size was 133. It is a prospective case control study. Statistical analysis, it was performed by using SPSS statistics 19. P-value is 0.05, which is considered statistically significant. The confidence interval was 95%. Inclusion criteria, the age between 6 to 30 years, hemoglobin more than 100 grams, more than 10 grams. Clinically diagnosed chronic tonsillitis, Paradise criteria. Exclusion criteria is bleeding and clotting disorders, enlarged tonsils, which is not chronic tonsillitis. Example, neoplasm abscess, chronic systemic illness, unilateral consular growth, and iatrogenic excessive bleed. Pre-operative assessment, all the 133 patients underwent detailed examination. If the patient was found to chronic tonsillitis, she asked for consent to be part of surgery under general anesthesia. Intraoperative assessment, all the patients underwent tonsillectomy by dissection and snare method under general anesthesia. To avoid surgeon bias, all the surgeries were performed by same surgeon with the same set of instruments. For the purpose of convenience, all the tonsils on the right side included in group 1 and the left side included in the group 2. The first parameter used was the time taken from first incision to the achieving complete hemostasis. As soon as the first incision was placed, time was started. So suction should be avoided. Suction was not used over the surgery to calculate accurately the amount of bed loss. In group 1 on the right side, the cotton ball was soaked in the normal saline and the fossa is applied with gentle pressure with the left index finger. In group 2 on the left side, the cotton ball soaked in 3% hydrogen peroxide placed in the fossa with gentle pressure by right index finger. The cotton ball was left for 2 minutes, after which it removed and fossa was observed for any bleed. The second parameter was amount of bed loss on each side. So the volume of normal saline and hydrogen peroxide was subtracted. The volume of blood on the pack calculated by the weight of the blood divided by the specific gravity of the blood. So among 133 patients, 23 of them bleeding, which is not controlled by local pressure. So excluded from our study, the sample size is cut down into 110. Post-operative assessment, all the patients received the same set of antibiotic and analgesics. Fossa was visualized every 6th hourly for the next 2 days to observe for any secondary hemorrhage. Coming to observation and results, in our study, 45% for male and 65% for female. The age group in between 15 to 20 years. Regarding time taken, in group 1, where NS was used to achieve hemostasis, it took 14 minutes 29 seconds. In group 1, where H2O2 was used it took 12 minutes 15 seconds. So in group 2, 14% lesser than the group 1. Regarding bed loss, in group 1 it is 56 ml, in group 2 47 ml. So in group 2, 16% lesser than the group 1. So the statistical significance is 0.001 in both the groups. Discussion, the beneficial effects of hydrogen peroxide ranging from its cost effectiveness to very less side effects. We have studied the same in our study and results pointed the bed loss and time taken to perform the surgery reduced in the side where H2O2 was used instead of NS. As a broad categorization, the bleed can be divided into vascular and mucosal. The venous bleed mostly from the peritonsillar vein. Mucosal bleed is accelerated by the movement of muscles of anterior and posterior pillar. So based on data obtained by us, there is enough evidence to prove that H2O2 can be used instead of various combinations like adrenaline, lignocaine, bupivacaine to control primary hemorrhage in post-tonsillectomy. Coming to conclusion, 3% hydrogen peroxide is a potent agent act as antimicrobial activity and hemostasis were placed in the transfer fossa post-tonsillectomy. So it is very effective in preventing bed loss, and also there is no serious complication associated with the H2O2 as hemostatic agent. So these are the references. Thank you, sir.
Okay. Thank you, doctor.
Thank you, sir. Can I leave, sir?
No, wait. Nagaraj sir, any questions?
No, sir. Actually, hydrogen peroxide in a general use, where do you use it? We use post-operatively, right? To
Yes,
remove
sir.
the clot. Right?
Yes, sir.
But how do you tell like it intraoperatively, during intraoperatively, how does it help? So how does the
Intraoperatively, we use 3% H2O2 undiluted 3 ml of H2O2 on both sides equally. So.
Yeah, what is the mode of action? Like what could be the according to you, what could be the mode of action of hydrogen peroxide?
It is mostly it occurs the local microvasculature and kills the fibroblasts. So it divided into nascent oxygen and water. This nascent oxygen has oxidative properties that leads to antimicrobial surface.
Okay, thank you.
Thank you, sir. Can I leave, sir?
Yeah.
Sir, this is Tonsillectomy, sir. Can I present, sir?
Yes, go ahead.
Okay, sir. Good afternoon, sir. This is Tonsillectomy, a study of preoperative and postoperative audiological evaluation following type 1 tympanoplasty. Introduction. Chronic otitis media is a long-standing infection of the middle ear cleft characterized by persistent or recurrent oral discharge, deafness, and perforation of the tympanic membrane. Mucosal type of chronic otitis media can be managed in two ways: conservative and surgical management. The aim of the middle ear surgery for hearing is reduction in the patient's hearing disability, not just closure of the airborne gap. Tympanoplasty is an operation to eradicate the disease in the middle ear and to reconstruct the hearing mechanism with or without mastoidectomy. FESS defined tympanoplasty is a surgical reconstruction of the tympano-ossicular system, and it includes canaloplasty, myoplasty, meringoplasty, and ossiculoplasty. Type 1 tympanoplasty is performed when there is tympanic membrane perforation without any ossicular damage. The incidence of the mucosal type of chronic otitis media is high in developing countries because of poor socioeconomic standards, poor nutrition, and lack of health education. It is an important cause of hearing impairment. This study deals with the functional outcome in series of patients who underwent type 1 tympanoplasty with underlay technique using temporalis fascia graft. Materials and methods. It is a prospective study in ENT department, SVS Medical College and Hospital for perforation of the tympanic membrane during the period from June 2022 to July 2023. 30 patients are included in the present study. Inclusion criteria: dry central perforation, conductive hearing loss, patients with inactive mucosal type of chronic otitis media with central perforation. Exclusion criteria: mixed or sensory neural type of hearing loss, patients with active tubotympanic disease, patients with atticoantral type or squamosal type of chronic otitis media, patients with previously operated for ear surgery. These are the pictures of tympanic membrane. This is the normal tympanic membrane where cone of light is seen, and we see the posterior central perforation, and this is the large perforation. Here we see the images of central perforation and temporalis fascia graft which is harvested. These are the images of the pre-op Puton audiogram and post-op Puton audiogram. Here we see in pre-op PTA, we see in left side 43.3 decibels of hearing loss. Where in post-op PTA, we see the improvement to 13 decibels. Methods of collection of data. All the patients who presented with chronic otitis media were submitted with an assessment protocol, history taking, specific physical examination, that is otoscopy and rhinoscopy, audiogram, examination under microscope to confirm the otoscopic findings. During history taking, all the patients were questioned about the disease onset, period of time onset, time spent without otorrhea, number of otologic infections per year, and if they had undergone any previous otologic surgeries. Routine investigations apart from examination under microscope were done in every case, which has provided useful information, that is perforation size, location, presence or absence of inflammatory mucosa in the middle ear. Radiologically, patient was assessed pneumatization status of the mastoid bone by X-ray Schuller's view. Puton audiogram is done in every selected patient. Average of hearing loss, air conduction threshold was calculated by selecting 500, 1000 and 2000 Hz frequencies. The operations were performed under general anesthesia using a microscope via post-oral incision under underlay technique. Temporalis fascia graft is used as a graft material. All the patients were followed after the surgery as usual, after 1 week, 2 weeks, 3 weeks and after 3 months. Observation: a period of 12 months was taken into study. A detailed information regarding age, sex, clinical findings, preoperative and postoperative hearing thresholds, preoperative airborne gap findings, complications following the surgery, status of the graft, and postoperative airborne gap findings are noted. Age distribution. I took the patients from the age 11 to 50 years. Here we see most common age group affected are 31 to 40 years.
where 44% of the patients are affected. This is the age distribution where 31 to 40 years age group are mostly affected. In sex distribution, mostly female persons are affected. 63% of the females and 37% of the males are affected in 30 patients. Operating side of the ear. In my study, left-sided patients are more affected. That is 67% of the patients are affected in left ear. Symptom distribution. Most of the patients, that is 100% of the patients, complain that have a complaint of intermittent otorrhea, which is followed by hearing loss, followed by earache, and followed by vertigo and tinnitus. Distribution of the laterality of the disease. 24 number of patients were affected unilaterally and 6 number of patients are affected bilaterally. This is the symptom distribution. Size of the perforation. Most of the patients are affected with a large size of perforation, that is 70 number of patients, that is 57% of people are affected with large central perforation. Preoperative hearing thresholds. 25 to 34 decibels decibels loss is seen in 6 number of patients. 35 to 44 decibels hearing loss is seen in 40 number of patients, and 45 to 54 decibel loss is seen in 10 number of patients. Complication rate. In post-operatively, we see the persistent discharge in 1 patient and graft failure in 3 patients and decreased hearing in 2 patients. Graft uptake rate. 27 number of patients have a good graft uptake, and there is complete graft failure in 0 number of patients, and medialization of graft is seen in 2 patients, and residual perforation is seen in 1 patient. Overall hearing improvement in the patients post-operatively. We see normal range of hearing in 17 number of patients and mild hearing loss in 10 number of patients. There is moderately severe hearing loss in 3 patients, that is rejected cases. Airborne gap in pure tone audiometry. Pre-op airborne gap is 23.66 in decibels. Post-op airborne gap is 13.6. Change in airborne gap is 9.8. To 40 years age group people are high, with the mean age being 39.8 years, indicating the fact that chronic suppurative otitis media is mainly the middle ear infection, which tends to occur more in 3rd decade of life and resolves to leave permanent perforations with conductive hearing loss in many cases. In our study, male to female ratio is 1:1.14, which is consistent with Gaurav Bhatni et al., in which male is to female ratio is 1:1.4, in which 37% of male and 63% of females are affected. Islam et al., M.R. Dawood et al., and H. Lokna et al. Shows similarly female preponderance, whereas in other studies like Shetty et al. And Mohammed et al. Shows male preponderance. In our study, intermittent otorrhea is seen in 100%, that is 30 number of patients, which is similar finding in studies like Mohammed et al. And Shetty et al. Tinnitus is present in 7% of cases, whereas Shetty et al. It is present in 18% of cases, and Lokna et al. 5.4% of cases. In our study, earache is present in 37% of cases, whereas in Shetty et al., earache is present in 39% of cases. Thus, most common presenting symptom is intermittent otorrhea. The most common complication is graft failure and decreased hearing, 10% and 6.66% respectively in our study. Graft take-up rate is 27, 90%. In graft failure, medialization of graft is seen in 2 and residual perforation is seen in 1. In our study, preoperative hearing airborne gap threshold is 35 to 44 decibels in 47% of patients. Preoperative air conduction threshold is 8.9 decibels.
Next. Yeah, cross your time.
Conclusion: intermittent otorrhea was the most common, and hearing loss was seen in 60% of the patients as presenting complaint in chronic otitis media. Hearing improvement was assessed by improvement in airborne gap in this study and was significant after type 1 tympanoplasty. Tympanoplasty is a beneficial procedure in hearing improvement. These are my references.
Candidate, please share your screen.
Thank you.
Next candidate, Dr. Mohit. Dr. Mohit.
Can I leave, sir?
Yeah, you can do.
Sir, myself, Ravali, can I present, sir?
Conductive hearing loss.
Yes, yes. Share your.
Good afternoon, everyone. Sir, am I audible?
Yes, yes. Continue.
Good afternoon, everyone. And myself, Ravali, I'm going to present the case series in Intrapolyp steroid injection in a case of Cyanonasal polyposis. It's a case series. So introduction, the Cyanonasal polyposis have a severe effect on patients' quality of life. Significant percent of the patients with chronic sinusitis. While there are several tools available to the otolaryngologist to help manage these polyps, steroids remain the cornerstone of medical therapy for this condition. Traditionally, steroids have been delivered systemically via oral medication or locally via topical washes and sprays. Steroid injection represents a potential method to deliver a high concentration of this anti-inflammatory medication to a local area. Over the years, intranasal steroid injections have come in and out of favor. So in the study, we discuss about the outcome of the intralesional steroid injection, which is given in the 10 cases of polyps. The outcome is measured based on the patient's symptoms, endoscopic evaluation, and CT findings after giving 3 doses of steroid injection. The aim of the study is to study the efficacy and safety of the intrapolyp steroid injection in the treatment of polyps. The materials and methods used, it is a hospital-based prospective study. The study duration is about 18 months, and this is conducted in the Emirates, Hyderabad. And the patient attending the ENT department after obtaining a informed consent will be taken. The sample size is 10 patients. The eligibility criteria, the inclusion criteria being all the patients between the 20 to 65 years old of either gender which are diagnosed with polyps. Exclusion criteria being fungal polyps, cystic fibrosis, any patients which are contraindicated to receive steroids, patient with a previous trial of medical or a surgical treatment of polyps, and the patient with locoregional complications such as hypertelorism and proptosis. The methodology, the patient clinical history is obtained and the associated symptomatology is recorded, such as nasal obstruction, nasal discharge, headache, and anosmia. After the clinical examination, further basic routine investigations are done, such as complete blood picture, absolute eosinophilic count, and DNA and CT scans are done to find the extent of the disease. The total 10 patients are treated by steroid injection, and this is the procedure. 1 ml of kinocort, which is Translone of 40 mg, is injected using 3 ml of syringe using 21 gauge needle. And before that, we pack the nose with 4% lignocaine with 0.05% of oxymetazoline for 10 minutes. The Translone is shaken vigorously to dissolve the whole particles, and it is injected into the polyp with a depth of 1 to 2 mm using a 0-degree endoscope. The 1 ml of Translone is injected inside all the polyps per side. All the patients have received injections bilaterally. The patient will return at a week interval till they complete a series of injections. The total of 3 injections will be administered in each patient. Each will receive about 80 mg per both sides at a time. The patient symptoms is recorded before and after the treatment by using the total nasal symptom score, endoscopic examination using the total nasal polyp score, which is TNPS, and CT imaging using Lid-Mackay score, which is used for assessment. This is the total nasal symptom score. It is a subjective scoring of the clinical disease severity. Patient symptoms were evaluated based on the questionnaire assessing nasal occlusion, rhinorrhea, sneezing, nasal itching, hyposmia, and nasal pain. So the severity of each single symptom was assessed with a 7-point scale, where 0 is no symptoms, 1 to 2 is mild, 3 to 4 is moderate, 5 to 6 is severe. The summation of all these nasal symptom scores provided the total nasal symptom score, which ranges from 0 to 36. The next coming is a polyp score. So we use 0-degree endoscope to assess the size of the polyps, where 0 is no polyps, 1 is it is above the level of inferior turbinate, 2 is extending down to the same level of inferior turbinate, 3 is severe polyps is extending much more down below the level of inferior turbinate. So it is calculated by sum of the scores in each side. The next coming is Lud-Mackay score. This is CT scan images of paranasal sinuses are evaluated in this. So left and right group of sinuses are classified into 6 parts: maxillary, anterior ethmoidal, posterior ethmoidal, sphenoid, frontal, and osteomyelitis complexes. The severity of the sinus mucosal inflammation or fluid accumulation is scored as 0, 1, 2. And 0 is no opacity, 1 is partial opacity, 2 is complete opacity. So this ranges from 0 to 12, and on the whole, left and right, it ranges from 0 to 24. So this is the data, the pre and post data of all the 10 patients, where the pre and post injection. The results are, out of 10 patients of cyanonasal polyps, 4 are females and 6 are males, aged between 20 to 65 years. And Lud-Mackay score, symptom score, and polyp scores are measured before and after giving the steroid injection, with average gap about 6 weeks of follow-up. The average mean Lud-Mackay score has improved from 19.5 to 12.5. Nasal symptom score has improved from 27.5 to 18.5. Polyp score from 5.2 to 3.5. In our patients, two patients has a history of cardiac surgery, and in which one has a pacemaker in situ and other patient underwent cardiac stenting. So 3 patients with a history of diabetes, there is no effect of steroid on blood sugar levels, any fluctuation on blood sugar levels. And 1 patient has a history of recurrence, where the patient had need for the FESS surgery. So the comparing the injection with the local nasal sprays were not included in the study. So this is the endoscopic evaluation, where the polyp score was 3 initially. After the 3 doses, we had again after the follow-up, patient came with decreasing in the symptoms, and the polyp score was measured as 2. So a study conducted by the Muzaffar, which is published in a journal Laryngoscope in 2016. In the study, the 90 patients with polyps divided into the 2 groups, where one group received oral prednisolone 1 mg per kg per day, tapered by 5 mg per day for 2 weeks, or to receive the other group being the Intrapolyp steroid injection, where the 40 mg triamcinolone was given up to 5 weeks with a 1 week interval. So total of 211 injections were given to the 45 patients, and there is no serious complications were observed. Both the groups showed significant decrease in polyp score, CT score, and the symptom score. And the plasma cortisol and ACTH levels of the injected patients were also normal before and after the treatment. So a study conducted by the William, it is a retrospective study, chart review, and the review of the medical literature to assess the safety for the intranasal steroid injection. There are 237 injections were performed, 152 were intraturbinate and 85 were intrapolyp. One of the intrapolyp injection resulted in the transient visual change that resolved spontaneously. So of the reported 1,17,669 injections were performed, 3 resulted in the visual complication, yielding an estimated visual complications rate of 0.003%. All these events resolved spontaneously and resulted in no permanent visual defects. Finally concluded that the intranasal steroid injections are safe, and stated that when performed correctly, there is an evidence to justify the use of methylprednisolone acetate and triamcinolone injections into inferior turbinate and the nasal polyps. This is the Lud-Mackay score before the steroid injection, which was the score was 14, and after the 3 doses of injection, the polyps showed complete regression. And the score is 2. So finally, I would like to conclude this review found that the intrapolyp steroid injection may be a safe and effective.
Time is up.
Okay. However, cases with extensive bulky polyps with resistant to complete. Thank you, sir.
Next presenter, Dr. Mohit. Please share your screen. All the presenters stick to the time. 7 minutes is the first. And 8 minutes is coming. Yeah, you can start your presentation, Dr. Mohit.
Yes, sir. Sir, am I visible?
Yeah, yeah.
How do I increase the screen?
Your screen is visible and your audio is also heard. Please go ahead.
Yes, sir. Outcome of conservative management and trichloroacetic acid quaternary in cases of traumatic tympanic membrane perforation. Tympanic membrane injury is a common element noted in ENT practice. For ENT surgeons, it is important to restore the functional integrity of tympanic membrane, failure of which results in persistent perforation, infections, hearing loss, and cholesteatoma. Historically, various treatment options are available, like conservative management, trichloroacetic acid quaternary, prosthetics, surgical closure, and etc. The tympanic membrane is located between external auditory canal and middle ear cleft. It is divided into two parts, pars tensa and pars flaccida. Pars tensa is further divided into 4 quadrants. Tympanic blood supply to the tympanic membrane comes from the deep part of maxillary artery, auriculotemporal nerve, and Oral's nerve supply the external part of the tympanic membrane. Jacobson's nerve or the ninth nerve supplies the internal part. Tympanic membrane aids in impedance matching. Aims and objectives of the study. The study Sir, am I audible?
No, there is some technical
Yes, you're
issues
audible.
there.
Go ahead.
Yes, sir. We want to compare the efficacy of.
Yeah, go ahead. Now we are audible.
Yes, sir. We want to compare the efficacy of conservative management and trichloroacetic acid quaternary in cases of traumatic tympanic membrane perforation. All the patients who were reported within 7 days of injury were included in the study. Patients with active middle ear infection, with systemic diseases like diabetes, patients with past history of middle ear disease, and who could not come for follow-up were excluded. After detailed clinical history, examination, hearing assessment, all the 40 patients were selected who were divided into 2 groups. First group, no active treatment was given. Patients were advised a course of antibiotic for 10 days, diet precautions were explained, and they were reviewed every week for following 8 weeks. In the second group, chemical cauterization was done with 50% trichloroacetic acid quaternary under microscope following local anesthesia with 4% lignogen. Here are our results. The most commonly affected age group was between 20 to 40 years, which is young adults. Left ear was more commonly affected than right ear. Most commonly, females were affected. Most of the perforations were limited to 1 quadrant, that is less than 4 mm. Most common mode of injury was slap injury or assault, followed by instrumentation with pointed objects, followed by noise-induced traumatic perforation, and then by fall. 99% of the cases had a single perforation, whereas 1 case had multiple perforations. Most common quadrant involved was the posterior superior quadrant, followed by anterior inferior quadrant. The most commonly, patient presented with phalgia or ear pain, following which hard of hearing, bleeding. Few cases even presented with ringing sensation in the ears. A study in the conservative group, 40% cases got infected, of which 4 cases did not heal completely within 8 weeks. Of the 12 uninfected cases, 10 cases healed completely within 8 weeks. Average time taken for uninfected cases was 20 days and infected cases was 37 days. In the second group, or the trichloroacetic acid quaternary group, 30% cases got infected, of which 1 case did not heal completely within 8 weeks. Of all the uninfected cases, 100% healing was achieved within 8 weeks. Average time taken for uninfected cases was 19 days and for infected cases was 36 days. Discussion. The incidence of perforation was high among young adults, that is 20 to 40 years. Females were more commonly affected than males. Left eardrum was more commonly affected. Most common mode of injury was slapping or assault, followed by sharp instruments. Posterior superior quadrant were more commonly involved in tympanic membrane perforation. Most patients presented with earache, followed by hard of hearing, then bleeding was seen. In both the groups, time taken for healing was almost double in the infected cases, implying infection delays healing. In uninfected cases, treatment modality did not influence the time of healing. Both conservative and in the trichloroacetic acid group, time of healing in uninfected cases was around 19 to 20 days. Overall healing rate achieved in conservative treatment group was 70% and in trichloroacetic acid quatri group was 95%. According to this study, the healing rate was observed better in cases that underwent trichloroacetic acid quatri than the conservative group. According to Keller, the lowest force required to cause perforation was 24 pounds and the highest force was 33 pounds of square inch. Contraction of intratympanic muscles offers no protection to eardrum. Patent eustachian tube and well-pneumatized mastoid offer protection against air pressure changes and traumatic tympanic membrane perforation. Epithelium of external drum grows at the rate of 0.5 mm per day. Hypertrophy and mitotic activity of perforated margins begins in 12 hours and inflammation and healing starts within 36 hours. Migration of outer epithelium and closure of perforation usually occurs in 14 to 21 days. According to various studies, traumatic tympanic membrane perforation heals within 6 to 8 hours. That is why we have selected 8 weeks as our study period. Cauterization of tympanic membrane margins with trichloroacetic acid quatri causes destruction of squamosal epithelium, freshening of the margins, starts inflammation, and helps in healing process. These are my references. Thank you, sir.
Yeah, hello.
Yes, sir.
You said the healing of the traumatic perforations. Okay, it all depends upon the size of the perforations or the multiples of the perforation. Any inference?
Any questions, sir and madam?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir, you're audible. Sir, in the study, most of the cases, that is 60 to 70% of the cases included, had a tympanic membrane perforation within 1/4 of the tympanic membrane, sir. That is less than 4 mm. The larger perforations don't tend to heal with chemical cauterization, sir.
Correct. Okay. And you said most of the time, in all your studies, there was a single perforation, but most of the time, the small central okay. Posterior and anything with respect to quadrants, do you have any impression with that? Anterior, inferior, and posterior, superior.
Yes, sir. In the posterior superior quadrant, we have to do it very skillfully, sir. Posterior superior quadrant, if we injure, it will injure the incudostapedial joint and lead to complications.
Correct. Yeah. So it's better, like most preferably, like it's better for a anterior inferior quadrant.
Yes, sir. Yes, sir.
Yes. Yeah. Fine. Thank you.
Thank you, sir.
Okay. Next presenter, Dr. Spurti. Please share your screen.
Share my screen. Sir, am I audible?
One instruction to all of you. Please keep your video screen on. You should be visible while presenting with the AOITSCON background.
Sir, am I audible?
Yeah, you are audible but not visible. Please.
Okay. One second. I'll make visible. Link unpaired. Visibility.
Dr. Spurti, to turn on your video, just exit screen share and come back again.
Oh, yes, sir. 1 second.
Without your video, we cannot allow it.
Now, video unpaired. My picture should be visible. Sir, just a second. Give me time. 1 second. Sir, am I visible?
Yes.
Okay, I'll share my screen. Okay, sir.
Yeah, go ahead.
Yes, sir. Sir, my topic is a comparative study of endoscopic DCR without and with intraoperative mitomycin C application in preventing the postoperative complications. Sir, FE4 or excessive watering from eye is a common complaint. Just a second. It's a common complaint among patients suffering from chronic dacrocystitis. It is a troublesome symptom for patients as it causes discomfort, blurring of vision, excoriation of the skin. So obstruction of the lacrimal pathways, whether congenital or acquired, it has to be corrected with a surgery, that is dacrocystorhinostomy. So the surgical procedure, it is nothing, dacrocystorhinostomy is a surgical procedure of diversion of the lacrimal float into the nose through an osteotomy done at the level of the lacrimal sac. Endoscopic DCR is more physiological because it preserves the lacrimal pump mechanism. But the major challenge here is to prevent the postoperative complications, which is affecting the success rate of the surgery. My aim is to study the efficacy. Sir, is my screen visible?
Yes, it is visible.
Yes. My aim is to study the efficacy of intraoperative mitomycin C in endoscopic DCR in preventing the postoperative complications. My objectives are to assess the outcomes of mitomycin C in preventing the postoperative granulations, postoperative synechia or radiation formations, and to prevent stenosis. It's a prospective study. It is done in our department, and my sample size is 20 patients for a study period of around 18 months. My inclusion criteria are patient aged 20 years and above with complaints of FE4A, along with patients with complaints of either deviated nasal septum, septal spurs or inferior turbinate hypertrophy, and patients with mucocele of lacrimal sac. Exclusion criteria are patient age less than 20 years, patient with previous history of DCR, patient with acute dacrocystitis or pyocele of lacrimal sac, pregnant and nursing mothers. Methodology: all the patients attending to the ENT OPD in our hospital with the complaints of FE4A have been included in our study. After informed consent, a detailed history, general examination, local ENT examination, ophthalmic examination that includes syringing, and diagnostic nasal endoscopy has been performed. And those patients who have diagnosed with other than nasal lacrimal obstruction, or along with that any other complaints like deviated nasal septum, septal spur, inferior turbinate hypertrophy or mucocele, such cases are also taken up for surgery, and simultaneous correction of nasal pathology has been done. A total of 20 patients diagnosed with nasolacrimal sac obstruction have been included in the study. I've divided them into two groups, and for the convenience, odd numbered patients have been included in group 1 without mitomycin C application, and even numbered patients undergoing DCR with mitomycin C application in group 2. And I've divided the patients 10 cases each. And how the technique is, once intraoperatively, that is endonasally, once an opening is made in the lacrimal sac, it is widened. And for group 2 patients, a surgical sponge that is embedded in mitomycin C is applied to the raw area of the lacrimal sac in a dose of 0.2 mg per ml for a period of over 5 minutes. After that, the removal of the sponge, the area is irrigated thoroughly with saline solution. The nasal flap mucosa, later the nasal flap mucosa and the lacrimal sac mucosa both are approximated so as to make it as a continuous lining. And here the gel foam is placed on the sac and the approximated flaps, and the nasal packing is done with sofromycin soaked ribbon gauze. The pack removal is done 48 hours post-operatively, and all the post-operations included in the study have been will be followed up at a period of first, second, 4, 12, and 24 weeks. So in post-operative period, what all I'm assessing is first thing the patency of the stoma, that is checked, one with the help of relief of epipora, and second it is done with the help of sac syringing. Sac syringing is done for the first 2 weeks, followed by 4th week, 12th week, and 24 weeks. And and next we'll do diagnostic nasal endoscopy. In endoscopies, I'll be checking for adhesions, granulations, and stenosis. That is done again for the first 2 weeks, followed by 4, 12, and 24 weeks. So this is the drug I've been used, and this is the dilution factor mitomycin C 0.2 mg per ml that is taken with gel foam, and here the mitomycin soaked gel foam is placed in the lacrimal sac. Then my observation and results, though all age groups are included in the study from around 20 to 70 years, most of the patients fall under the age group of 40 to 50 years, followed by 20 to 30 years. Most of the patients are females, that is female have outnumbered the males, and dacrocystitis is actually the most common condition in females compared to males, and my ratio is around 3:1%. In all these cases, epiphora is the chief complaint seen in all the 20 cases. Along with that, 25% of the patients, they are presented with swelling at the medial canthus, and around 30% of the patients, they are presented with nasal obstruction. My DNA findings, sir, around 37% patients have normal nasal findings. They only presented with nasal lacrimal duct obstruction, and remaining 31% patients, they have deviated nasal septum, and another 16% patients, they either presented with spur or concha. And syringing results, based on the syringing results, most of the patients we operated were right-sided. I mean, the right-sided, they had right-sided nasolacrimal duct obstruction. The side was non-patent. And follow-up. The follow-up results are actually after 6 months. In 6 months, that is group 1, where there is without Mitomycin C application. 2 cases, they presented with no relief in epiphora, and 2 have non-patent stoma. 1 cases, they presented with granulations and Sinoke formation. Whereas in group 2, where we used Mitomycin C, there's 1 patient who presented with no relief in epiphora, with they're having the non-patent stoma, and 1 of the patient had granulations and Sinoke formation. So the success and failure rate have been calculated after 6 months follow-up of the patients. In group 1 patients who has without Mitomycin C application, the success rate was around 80%, and in group 2 patients, the success rate is around 90%. So discussion. Endoscopic dacryocystoid has some advantages over the external approach DCR, as it is a less invasive method and with no skin incision. But the success rate of this operation has not reached the level of external method. In this study, here I've used a wound healing inhibitor, Mitomycin C, which was used intraoperatively to prevent the closure of the osteum during operation. It reduces the fibroblast collagen synthesis by inhibiting the DNA-dependent RNA synthesis and cellular proliferation in any
1
period of the
minute
cell
more
cycle.
to go.
When used as a topical 0.2 mg solution, intraoperative application of Mitomycin C affects the wound healing process. My study results have been compared with other studies. One study is Ganesh Kulkarni, and according to his study, the success rate was 96%. The second study is Vikas Gupta. He taken the sample size of 26 patients, and his success rate was 92.3%. And the third study is Akriti Sharma. Her success rate was 93.4%. My sample study was 10 patients, and I had a success rate of 90%. And to conclude, we have found that topical Mitomycin C is safe, easy to use, and an effective agent by means of preventing adhesions and osteum closure in patients undergoing endoscopic DCR. So this adjunctive use of wound healing inhibitor is considered to increase the success rate of endoscopic endonasal DCR. These are my references, sir. Thank you.
Dr. Spurti, you got a institutional ethical committee clearance for this?
Yes, ma'am, I've got the clearance.
It is a random selection. Don't you think it's the right to select their type of treatment?
No, actually, we have explained the patients also that about the drug and the side effect. In the study has actually been published by many people before, ma'am. So I have got the clearance and I've explained it. It's a topical application, and the side effects have been less compared to. I mean, there are no such side effects with the topical application.
Okay.
Next presenter.
Yes, sir.
Satyasree.
Once you have presented, you can exit the.
Thank you, sir. Good afternoon, everyone. Today I'm going to present my study.
You can't see
Evaluation
your
of
screen.
patients.
Share your screen.
Sir?
Can't see your screen.
Sir, is it visible, sir, now?
Go ahead. I can see the screen and I can see you also.
Yeah.
Oh, thank you, ma'am. Can I start, sir?
Yep. 1 second.
Yes, sir.
Dr. Rakesh, can you see this screen? Harsha? Hello.
Can I start, sir?
No, even I can't able to see your screen, sir.
Yeah. Harsha? Dr. Rakesh, can you see the screen? Ramesh sir?
Yes. I can see the screen.
Okay.
Full screen. Start with full screen.
Yes.
Start with
But
full
the
screen.
candidate is not visible, sir.
Your video should be visible.
Can I start, sir?
Your video should be visible.
Yeah, video is visible, sir.
No. Not visible.
It is not visible, sir. The video is not visible.
Successfully, don't change slides. Just on your video and present. On your video and present. Yeah. Now you can start. Go ahead.
Thank you, sir. Good afternoon, everyone. Today I'm going to present my study, Evaluation of Patients Presenting with Snoring in the Rural Tertiary Care Hospital. Introduction. Snoring is one of the most common sleep-related breathing problems in both adults and in children. The symptom can present in isolation, or it can be one of the common symptoms of the sleep disorder breathing. Though it is only seen as a common social problem, it has been associated with the rise in the comorbid diseases such as asthma, allergies, decreased cognitive function, behavioral problems, increased obesity in the pediatric population. Whereas in adults, even without the apneic episodes, it has been associated with the impaired quality of life, increased risk of accidents, increased rate of hypertension, coronary artery disease, arrhythmias, diabetes mellitus, stroke, and increased mortality. So what is snoring? Snoring is a rough rattling sound produced due to the vibration of the soft palate and the oropharyngeal walls during sleep. This occurs because of the airway obstruction. The airway obstruction can be partial or complete. The risk factors include male gender, increasing age, obesity, smoking, alcohol, physical inactivity. The predisposing factors include both congenital and the acquired causes. Congenital causes include structural factors such as mid-phase hypoplasia, cleft palate, retinognathia, micrograthia, macroglossia, adenotonsillar hypertrophy, septal deviation. Genetic factors include Down syndrome, Treacher-Collins syndrome, Goldenhar syndrome, cystic fibrosis. Neuromuscular disorders include cerebral palsy, muscular dystrophies. Acquired conditions include infective causes such as chronic rhinosinusitis, adenoiditis, tonsillitis, upper respiratory tract infections. Allergic causes include allergic rhinitis, nasal polyposis. Neoplasms include adenoma, nasopharyngeal carcinoma. Miscellaneous factors include foreign body, nose, obesity, alcohol consumption, and smoking. So the aim of my study is to evaluate the patient presenting to the ENT department with the complaints of snoring. Objectives is to find the ENT causes leading to snoring in these patients. So the study design is a cross-sectional study, and it is conducted in our institute. The study population was 30 patients. The study subjects will be the patients with the complaints of snoring, and all age groups are included. These patients are interviewed based on questionnaires. For adults, it will be a Berlin questionnaire. For children, pediatric sleep questionnaire was used. The general information such as body weight, height, neck circumference are taken, and then the patient undergoes thorough clinical examination along with the diagnostic nasal endoscopy, video laryngoscopy. Patients below 12 years of age are evaluated with the radiological investigations. Coming to the results, the study sample size was 30 patients. In them, about 14 were children and 16 were adults. Sex distribution: in children, about 9 were males and 5 were females, and in adults, about 12 were males and 4 were females. BMI was calculated, and it is noted that about 11 out of 14 children were underweight. In contrast to the adults, in them about 10 patients were overweight and obese. The children were
interviewed along with the parents with the pediatric sleep questionnaire, and it was noted that about 8 of them were the loud snorers, and with 6 of them having mouth breathing during the daytime, and about 2 patients had apneic episodes during sleep with daytime sleepiness and were overweight. Coming to the clinical examination, about 9 patients had endotonsillar hypertrophy, only 2 patients had adenoid hypertrophy, 2 patients had allergic rhinitis, and only 1 patient had chronic rhinosinusitis. The adults were interviewed along with the parents or partner with the Berlin questionnaire, and it was noted that about 5 patients were loud snorers, with 5 of them having known history of the hypertension. About 3 of them had apneic episodes during sleep, with 2 of them having daytime sleepiness. About 5 of them also had a history of alcohol consumption, with 3 of them having smoking habits. The clinical examination was done, and it was noted that about 8 patients had macroglossia, 3 patients had chronic rhinosinusitis with polyps, 2 patients had chronic rhinosinusitis without polyps, 2 patients had tonsillar hypertrophy, 1 patient has adenoid hypertrophy, and 1 patient had cleft palate. Discussion. In my study, one of the risk factors observed was the male gender. The ratio between the male and female was 3:1, which was similar to the study conducted by the Rajendra Prasad and Rajiv, but they had about 2.35:1 ratio. The most common cause in children noticed was the adenotonsillar hypertrophy, which was about 64.28% in my study, in comparison to the 34.74% noted in the study conducted in China. About 43.4% of the study sample were loud snorers, which was also seen in study conducted by the Abhijit Singh and Suryakant, which was about 58.9%. So the conclusion, snoring was once thought as a harmless problem, but it has been implicated with the severe health problems, and even also precursor to the obstructive sleep apnea. The most common cause in the children seen in my study was adenotonsillar hypertrophy, most common cause, and the least common cause was chronic rhinosinusitis. In adults, macroglossia was noted as the most common cause, and cleft palate was noted as the least common cause. And therefore, early detection and timely intervention is important even in the absence of the associated sleep apnea. And these are my references, sir. Thank you.
Hello, am I
Yes, sir.
audible? In all your cases, it was just a snoring or any OSA?
Sir?
Is that all cases are only snoring, or is there any OSA, that is obstructive sleep apnea?
Sir, about 2 patients in children and 3 patients in adults had OSA, sir. Rest all had only snoring complaints, sir.
Okay, children, I agree. Okay, but what about adults, 3 patients? What is your inference with that OSA, obstructive sleep apnea?
Sir, I didn't understand.
So you had 3 cases of adult OSA,
Yes,
right?
sir. Yes, sir.
Okay. So what is your intake in that? Because see, adenoids, what is the site of obstruction for snoring or OSA in the 3 cases?
Sir, they had macroglossia, sir, along with the increase the neck circumference, sir, in all 3 cases.
All 3 are macroglossia?
Sir?
All the 3 patients were macroglossia?
Yes, sir. All the 3 patients had macroglossia, sir, along with increased neck circumference, sir.
Okay. Okay. Thank you.
Thank you, sir.
Next presenter. Next presenter.
Veera Venkata Sai Vinila. Next presenter.
Please share your screen. You are not audible. Kindly reshare. We can see your screen, but your voice is not.
We cannot hear you, madam.
Now, sir, am I
Yeah.
audible, sir?
Yeah, you are audible now.
Yes.
Yes.
Go ahead, madam.
Good afternoon, sirs and ma'am. My case series is a comparative study. It's a comparison of antibiotic steroid pack and 10% ectamol glycerin pack as an effective treatment modality in acute otitis externa. I'm Dr. Vinila. Acute otitis externa, it is an inflammatory disorder of the skin of the external auditory canal. It can present as a diffuse or localized form of inflammation of the external ear canal. Skin is adherent firmly to the cartilage of the external auditory canal. Acute otitis externa, it has a prevalence of 0.4% per year and affects 10% of the population once during their lifetime. The most common pathogens are Pseudomonas aeruginosa and Staphylococcus aureus. Other pathogens are principally gram-negative organisms. Fungal involvement is uncommon, but may be more common after a treatment of acute otitis externa with topical or less often systemic antibiotics. The etiology is multifactorial. Any condition that disturbs the lipid balance of the ear will predispose an individual to the otitis externa. Regular cleaning of the ear canal removes the cerumen, which is an important barrier to moisture and hydration. Cerumen creates a slightly acidic pH that inhibits infection, especially by Pseudomonas aeruginosa, but can be altered by water exposure, aggressive cleaning, soapy deposits, or alkaline eardrops. Hearing aids and other factors such as sweating, allergy, and stress have been implicated in the pathogenesis of acute otitis externa. Patients present with a history of earache, ear discharge, itching, and sometimes hard of hearing. The common signs are erythema, a localized swelling to a diffuse canal edema, a positive tragal sign, and a displacement of the ear pinna. The most effective part of treatment is oral toileting. All the purulent material and the desquamated debris should be thoroughly removed, following by canal packing to allow the penetration of the antimicrobial therapy. Oral packing plays an important role in acute otitis externa, along with the antibiotic and analgesic systemically. Inflammation of the external auditory canal disturbs the periosteal and the perichondrial lining, and it stretches the nerve fibers, which causes severe pain. So the oral pack acts mechanically, providing a splinting action to prevent the stretch of the nerve. The objective of my study is to compare the efficacy of the 10% ectamol glycerin packs and antibiotic steroid packs in the treatment of acute otitis externa. It is a prospective study done in 20 patients who came to our outpatient department and diagnosed clinically with acute otitis externa. Inclusion criteria 10 to 60 years of age, both the genders, acute otitis externa with external auditory canal edema. Exclusion criteria age less than 10 years and more than 60 years, bilateral otitis externa with other ear conditions such as chronic suppurative otitis media, acute suppurative otitis media, otomycosis, with previous ear surgeries and mentally challenged patients. Diagnosis was done by history, physical examination, and otoscopic examination, and examination under microscope whenever required. Thorough oral titrating was done in included patients by removing all the purulent materials and the desquamated debris. A sterile cotton wick impregnated with either the 10% ectomol glycerin or antibiotic steroid ointment is placed in the external auditory canal. Patients who needed oral packing were categorized into group A and B. The first group A of 10 patients were treated with 10% IG packing and group B with 10 patients with steroid antibiotic ointment pack. So before oral packing was carried out, pain was assessed using visual analog scale. It is from 0 to 10, no pain, moderate pain, and severe pain. The scoring system was explained and patients were asked to make a point on the line that will represent their pain correctly. The score of the pain on the first visit was recorded. Both groups of patients were evaluated after 48 hours for assessment of the pain on the basis of the tragal tenderness by the same visual analog scale method. Pain after 48 hours was compared with pain of first visit. A statistical analysis of all the collected data was carried out using SPSS version 20.0. The p-value less than 0.05 was considered statistically significant. In our study, there were 20 patients who have been diagnosed with acute otitis externa with 10 in each group. Out of 20 patients, there were 65% male patients and 35% female with male domination. Patients aged less than 40 years were more in number than more than 40 years. Treatment with steroid antibiotic ointment has significant reduction in pain after 48 hours. No one had severe pain after 48 hours. Only 30% of them had moderate pain and 70% had only mild pain. Whereas in patients with 10% IG packs, 30% had severe pain, 50% had moderate pain, and 20% had mild pain. Our result was statistically significant with p-value less than 0.017. This is the gender-wise distribution. In IgVic, in both the IgVic and antibiotic steroid Vics, there is male predominance. Age-wise distribution, more than 40 years, there are more number of people in less than 40 years. And this is the pain score showing the reduction of pain after 48 hours. The reduction of pain is more in antibiotic steroid Vic after 48 hours. Discussion. Acute otitis externa is the most common acute inflammatory condition of the external ear. It is usually seen in hot and humid climates. Idiopathologically, mostly the conditions infectious and non-infectious, hampering the lipid or acid balance of the ear canal, leads to acute otitis externa. It has two self-defense mechanisms, presence of cerumen and epithelial migration of the skin. The treatment is mainly to decrease the pain and edema. Both topical and systemic treatments are available. In our study, we used 10% IG packs and steroid antibiotic ointment ear packs. IG packs is 9:1 glycerol with ectomol. The action, glycerin is hygroscopic and also emollient. It reduces itching. Steroid acts by reducing the edema and controls infection by antibiotic action. Our results show significant results with steroid antibiotic cream than with 10% IG packs. The duration of treatment, number of visits, and cost burden for the patients was reduced. The studies published by Adhikari et al. Showed significant decrease in pain and number of visits. A prospective study by Jasdeep Monga showed significant similar effect in both the groups, but they still recommended 10% IG packs. The conclusion, although both the ear packs can be used in acute otitis externa, use of steroid antibiotic pack gives earlier relief of pain, significantly less number of visits, and reduced cost burden. Thus, steroid antibiotic pack is better than 10% IG packs in giving rapid relief of symptoms in acute otitis externa. These are my references. Thank you, sir.
Okay.
Thank you.
Thank you.
Any questions, sir and ma'am?
No
Just
questions.
share your screen.
Dr. Shravan.
Shravan?
Yes, sir.
Yeah. Please share your screen.
Dr. Shravan, please share your.
Okay, sir. Shall I start?
Yeah, please.
Yeah.
Good afternoon, everyone. My name is Shravan. I am going to present case series on goiter, our institutional experience. Am I audible, sir?
Yes.
So, introduction. Goiter is defined as enlargement of thyroid. WHO defined goiter as a thyroid gland whose lateral lobes have a volume greater than terminal phalanx of thumb of person being examined. The thyroid gland enlargement may be physiological or pathological. Goiter can be associated with euthyroidism, hypothyroidism, or hyperthyroidism. The prevalence of goiter in our country is increasing. Hello.
Yeah, continue.
So, evaluation of goiter requires thorough clinical examination, investigations like thyroid function test, ultrasound, fine needle aspiration cytology, contrast enhanced computer tomography, histopathological examination. Criteria helping in diagnosis is Bethesda and PIRATS. Bethesda classification system for reporting of thyroid gland, fine needle aspiration cytology specimens. Category 1, non-diagnostic or unsatisfactory. Category 2, benign. Category 3, atypia, follicular lesion of undetermined significance. Category 4 is suspicious of follicular neoplasm. Category 5 is suspicious of malignancy. Category 6 is malignant. Thyroid imaging reporting and data system refers to risk stratification system for thyroid lesions usually based on ultrasound features. Category 1 is normal thyroid gland. Category 2 is benign conditions. Category 3 is probably benign nodules. Category 4 is suspicious nodules. Category 5 is probably malignant nodules. Category 6 is biopsy proven malignancy. This study is about our experience of goiter cases presented in our medical institution. Methodology, retrospective study done on patients attending ENT OPD of Bhaskar General Hospital with complaints of swelling in the thyroid region. Study period is July 2014 to July 2023. Results, age distribution. Most of the patients belong to age group 31 to 40, followed by 21 to 30 group, with the least among beyond 50 years of age. Sex distribution. The incidence is females is more with 97% and in males it is 17%. Results of fine needle aspiration cytology. Most common is colloid followed by adenoma. The least incidence is with suspicious follicular adenoma. Results of USG neck. Colloid goiter with cystic changes is the most common, followed by follicular adenoma with the least suspicious carcinoma. Surgical procedure done. Hemithyroidectomy and total thyroidectomy. Left hemithyroidectomy 38 patients. In right hemithyroidectomy 51 patients, and total thyroidectomy was done in 25 patients. Histopathology report, colloid goiter with cystic changes in 67 cases and nodular goiter with cystic changes in 5 cases, follicular adenoma in 22 cases, Hashimoto thyroiditis in 10% of cases, and papillary carcinoma in 8 cases, follicular carcinoma in 2 cases. So, analysis. In the present study, majority of the patients fall in the age group of 31 to 40 years, followed by 21 to 30 and followed by 41 to 50. In our study, majority of patients are females. Fine needle aspiration cytology has benign lesions. The incidence of benign lesions is more. Ultrasonographic findings in our study has majority of colloid goiter with cystic changes. Surgery is the treatment of choice in majority of the cases. In majority of the patients, surgery performed was hemithyroidectomy. Histopathological findings in our study has majority of colloid goiter with cystic change. Discussion. Highest number of patients were in 31 to 40 year age group. In similar studies performed by Roth et al., it was second and third decades of life. Most of the cases were females with a male to female ratio 1:5.6. This is comparable to a study done by Mandel et al. Most of the thyroid swellings in our study were colloid goiters. Fine needle aspiration cytology is a well-established and cost-effective diagnostic test for evaluation of the thyroid disorders. USG is helpful in assessing the location and type of lesion and differentiating solid from cystic swellings. USG-guided FNAC is known to increase the diagnostic yield in comparison to conventional FNAC. The type of thyroid surgery depends on the size and location of the swelling and fixity to underlying structures. Most of our patients underwent hemithyroidectomy. 7 patients had a voice change post-operatively, for which follow-up was done along with conservative management. Recovery of the voice occurred in 5 patients after 6 weeks. 3 patients after undergoing total thyroidectomy had tingling and numbness along with parcopedal spasm. Intravenous calcium gluconate was given. Permanent calcium supplementation and thyroxine dosage 100 micrograms once a day was prescribed with 3 monthly thyroid function tests. So conclusion, most of the thyroid enlargement cases with females and diagnosed as colloid goiters. Carcinoma incidence was 8.5% in our study. This study helped us to know the incidence of thyroid enlargement and their histopathological diagnosis. Limitations of our study. Few patients missed long-term follow-up. Sample size is small. References. Thank you. Hello.
Any questions, sir?
Yeah, doctor. Your most cases were colloid cases, right?
Yes, sir.
And what about the incidence of, you said around 8% was the malignancies?
Sir?
Around 8% was the malignancies, right?
Yes, sir. Yes.
In that malignancies, which could be and around 8%, which was the most commonest ones did you came out?
Papillary carcinoma, sir.
Papillary carcinoma.
Papillary carcinoma, followed by follicular carcinoma.
So papillary followed by follicular.
Yes, sir.
Okay. So according to you, the most common criteria would be a first thyroid function test followed by ultrasound and ultrasound-guided FNAC. That is going to help us out.
Yes, sir.
Yeah. Fine, doctor. Thank you.
Okay. Next presenter, Dr. Tejas.
Yes, sir.
Please start.
Yes, sir. Am I visible, sir?
Yeah.
Okay, sir. Good afternoon, all. I'm Dr. Tejas, and I'll be presenting case series on histopathological evaluation of nasal masses, a retrospective study in our tertiary care center. So, introduction. Variety of non-neoplastic and neoplastic conditions involve the nasal cavity and paranasal sinuses. So, the symptomatology of nasal masses are similar, and using advanced imaging, a presumptive diagnosis is made and confirmed with the help of histopathological examination. Aim of my study was to enumerate and find the incidence of various nasal masses based on histopathology. Methodology. A retrospective observational study was conducted in 60 patients for a duration of 1 year from June 2022 to May 2023. Investigations done included routine blood investigations, diagnostic nasal endoscopy, radiological imaging, and histopathological evaluation of nasal masses. Inclusion criteria: patients who presented with nasal mass and age group considered was 18 years to 80 years. Exclusion criteria: nasopharyngeal masses protruding into nasal cavity and age group less than 80 years and more than 80 years. So the results obtained were as follows. So the demographic data for cyanonasal masses showed that males 35 number and females 25 number, so total 60. So in that, males 59% were more commonly affected with cyanonasal masses than females, and the mean age group was 37.45 plus or minus 13.23. So a pie chart is depicted here showing the gender details. Out of the cyanonasal masses, 88% were non-neoplastic and 12 were neoplastic. Out of the neoplastic 12% masses, 14% were malignant and rest 86% were benign. So the results obtained showed, based on histopathology, nasal polyp, that is anthropoanal, is 32 in number, which is 53.1%. Nasal polyp ethmoidal was 10 in number, 16.5%. Inverted papilloma and nasal polyp, that was ethmoidal plus maxillary, accounted to 3 cases, that was 5% each. Nasal capillary hemangioma, we had 2 cases, accounting for 3.4%. Rhinosporosis, 2 cases. Aspergillus and mucormycosis presenting as nasal masses, as cyanonasal masses, we had 2 cases and 1 case respectively. We had a case of adenocarcinoma, a single case. A case of granulomatosis with polyangiitis, vaginous granulomatosis presenting as cyanonasal mass, that is 1 case. Squamous papilloma, we had a single case. Angiomatous polyp, we had a single case, and a single case of nasal pyogenic granuloma. So this chart shows the male and female distribution for various cyanonasal masses. So in this, we can find that for ethmoidal polyposis, females were more commonly affected than males, whereas for anthropoanal polyp, males were more commonly affected than female. Usually for cyanonasal masses, males are more commonly affected than female. So for anthropoanal polyp, comparing with other studies, is in conclusion, but not for ethmoidal polyp. And inverted papilloma, we had 3 cases, out of which 2 were males, 1 female. Rhinosporosis, we had 2 cases, accounting for equal number of males and females, 1 each. Same for nasal capillary hemangioma. Coming to discussion part, so in this study, we observed that males 35 number, 59% were more commonly affected than females, that is 25 number, 41%. So this is in comparison with other studies that are conducted by Swami et al. And Ayushi et al. And Latu et al. Age of the participant ranged from 80 to 70 years with mean of 35.4 plus or minus 13.3. So nasal polyps were the most common cyanonasal masses, accounting for 75%. Then came inverted papilloma, 5%. Then rhinosporosis, 3.3%. So in case of non-neoplastic polyps, that is comparing ethmoidal and anthropoanal, we had more incidence of anthropoanal polyp, that is 53% compared to ethmoidal polyp. Inverted papilloma accounted for 5% incidence. Coming to invasive fungal infections, we had a total of 5% of cases, that is 3 cases. So they often present as necrotic cyanonasal masses, so same as in our case. And in our case, we had a single case of mucor that accounted for 1.7%, and 2 cases, that is 3.4%, showed aspergillosis. So a diagram is there down depicting a polyp with fungal ball in case of mucor. Rhinosporosis accounted for 3.4% of cases. For malignant lesions, we had a single case of adenocarcinoma that presented as cyanonasal mass. So the conclusion of my study is, the purpose of this study was to emphasize the role of biopsy and histopathological examination as an essential part of evaluation of patients with cyanonasal masses for a definitive diagnosis. And with this approach, we can ensure timely intervention, and any adjunctive therapy, if required, can be provided to prevent any future complications. These are my references, and thank you. Hello, sir.
Yeah, okay. Thank you, doctor.
Okay, sir. Shall I leave, sir?
Yeah.
Okay. Yeah. Next, Amulya.
Yes, sir.
Okay, please start.
One minute, 4 minutes, sir. Sir, is it visible, sir?
Yes, yes.
Good afternoon, sir. Today, my topic is a comparison of preoperative FNAC with postoperative histopathological examination in thyroid swellings. It's a retrospective study. And introduction, thyroid swellings are one of the most common swellings that were presented to the ENT department. A thyroid nodule is either clinically palpable or ultrasound detected. Usually, FNAC is the initial assessment that we can do for the histological assessment of the thyroid swelling, because FNAC is simple, cost effective, and can be, it is minimally invasive, which can be performed at the outpatient basis And the main aim of study is to detect the diagnostic accuracy of the FNAC of thyroid swellings with that of postoperative histopathological examination results, which was based on the histopathology report. And materials and methods, study design is of a retrospective observational study, and study duration is of 1 year, that is from March 2022 to February 2023. Study population, it is of 60 cases who presented to ENT department, and inclusion criteria, all cases with thyroid swellings who were studied in detail with detailed clinical examination and the investigations. And exclusion criteria, all the neck swellings other than the thyroid swellings are excluded. And methodology, FNAC was carried out by the pathologist with 23 gauge needle, and smears were fixed with the 95% alcohol, and staining was done by papiniculate stain. And according to the FNAC report, patients underwent thyroidectomy, and properly after planning for the thyroidectomy, the specimen was processed in the automated tissue processing unit and sent for the histopathological examination. And finally, the report of FNAC and HPE was compared, and the validity of the FNAC with that of HPE is assessed. And in our study, it is of 60 patients, where 7 were male and 53 were female patients. And in age, the most common age group was 50 to 60 patients, where there were 24 patients. And after that, it was followed by 30 to 40 group of patients. And results, the FNAC was classified according to the Bethesda system, and among the Bethesda grades, the most common patients were found in Bethesda 2, that is of benign, and next it was followed by Bethesda 5, which was suspicious for malignancy. There were 6 cases, and that was followed by the Bethesda 6 grade, which was malignant, where 4 patients were presented. And incidence, as per the histopathological report, most of the cases were nodular colloid goiter, that is of benign, where 42 patients were present. And that was followed by the follicular adenoma, which was also a benign, well encapsulated tumor, where 7 patients were there. And that was followed by the papillary carcinoma, which was malignant, where 7 cases were there. And the Hashimoto thyroiditis and the follicular carcinoma, there were 2 cases and the 1 case. And this is a final comparison where we compared FNAC with that of histopathology. Among the nodular colloid goiter, where FNAC presented with 50 patients, and where again it was correlated with the histopathological examination, there were 42 patients.
This is the final comparison, and 3 groups were classified, where group 1 is of benign, group 2 is of suspicious of malignancy, and group 3 is of malignant. And in this group 1, number of benign patients where FNAC was diagnosed was 50 patients. Among that, it was 42 patients were correlated with that of histopathological examination, and the percentage of correlation was 84%. And discordance was discordance cases were it is of 16% was there, and suspicious of malignancy, number of cases that FNAC was diagnosed was 6 patients, and HPE was correlated only 3 cases. So that discordance was 50%, and that correlation is also 50%. And malignant cases, it was diagnosed as papillary carcinoma of thyroid. So correlation and the discordance, there is no discordance, and the correlation was 100%. And the coming to the discussion, the diagnosis of papillary carcinoma of thyroid by FNAC is reliable and accurate because the sensitivity and the specificity was 100%. In case of follicular neoplasm, the sensitivity of FNAC is about 90% and specificity is less than of 50%. So that it limits the usefulness of the FNAC, because this FNAC can't detect the capsular invasion or vascular invasion. So this FNAC can't differentiate between the follicular adenoma and the follicular carcinoma. In the present study, concordance between FNAC and the HP is of 92.6%, and the results were statistically significant, where significance is less than 0.05%. That is statistically significant. And coming to the conclusion, in this study, findings were revealed that FNAC of thyroid lesions has high accuracy, sensitivity, and the specificity, allowing it as a first assessment for knowing the histological pattern of the thyroid swelling. Hence, we can properly counsel the patient for the proper surgery and further management. But still, HP remains the superior than FNAC. Hence, the HP remains the final diagnostic tool, because FNAC cannot differentiate between the adenoma and the carcinoma, of follicular adenoma and the follicular carcinoma. Hence, the final histopathological examination is considered as a gold standard in the investigation for proceeding for further management. This is the reference, sir. Sir.
Okay, thank you, Amulya.
So can I lead, sir?
Okay.
Okay, sir, thank you.
Okay. Next, Atul Das.
Good morning, sir. Am I visible, sir?
Yeah, you are not visible. Click.
Hello, good morning, sir. Am I visible, sir?
Yes, yes.
Sir, so today I will be presenting on a topic on pediatric rhinosinusitis. So it's a case series which was done in our hospital. So introduction to this topic, rhinosinusitis is one of the most common diseases during childhood. It is usually following a URTI. Most of the cases will be indolent in nature, but about 5 to 10% may go on to develop complications. It should be identified as early as possible, and we should intervene as immediately as possible, as it can lead to significant morbidity and mortality. So it can be classified as acute rhinosinusitis, chronic rhinosinusitis, and fungal rhinosinusitis. So among the acute, it can be viral or bacterial, and fungal, it can be allergic fungal rhinosinusitis or invasive fungal rhinosinusitis. So aims and objective of the studies was to study the clinical manifestations, frequency of complications, and treatment outcomes in a series of pediatric rhinosinusitis cases. So this is a retrospective study of pediatric patients presented with rhinosinusitis in the tertiary center in Telangana. The study period was from June 2022 to June 2023. It included patients who required surgical management. So thorough history was taken, necessary investigation was done, followed by medical and surgical treatment. So inclusion criteria for this study was children up to the age of 14 who required surgical management, and patients with any adenoiditis and with any bleeding disorders were excluded. So in this study, there was a total of 11 patients, out of which 7 patients were noted to have acute bacterial rhinosinusitis, and 4 patients were noted to have allergic fungal rhinosinusitis. The usual presenting age was 5 to 14, with a higher incidence among males. And the common presenting symptoms include nasal congestion, rhinorrhea, cough, and facial pain. Imaging studies such as CT-PNS were done and to assess the severity of the disease. So in our study, about 64% of the cases had bacterial sinusitis and 36% had fungal rhinosinusitis. So coming into the complications which we encountered in the studies, 1 patient was noted to have preceptal cellulitis, 3 patients were noted to have orbital cellulitis, and 1 patient was noted to have intracranial complications. So in our study, 55% of the cases didn't have any complications, whereas 27% had orbital cellulitis, followed by 9% with preceptal cellulitis and 9% with intracranial complication. So this was one of the cases which was taken. So this is the patient with the left orbital facial cellulitis, and this is the CT coronal section which showed soft tissue attenuation in the left maxillary and ethmoid region, which is in the left nasal cavity in comparison with the right. And even on the MRI orbit, we can see the hyperintensities in the periorbital region on T2 weighted MRIs. So this is a different patient with similar presentation with the right orbital cellulitis. Here also we can see the soft tissue attenuation in the left maxillary, ethmoid, sphenoid sinuses with the involvement of a right orbit as well. This is again the different cuts for the same patient, which we can see the hyperdensities as well within the ethmoidal sinuses. This is the axial view. So this was one patient who presented with intracranial complication. We can see the attenuation here, which is suggestive of hyperintense attenuation, which is suggestive of inflammatory lesion. It could be meningitis or cerebritis. So this was the intra pictures which was taken. This is the left nasal cavity. This is after the left MMA, ethmoidotomy, and left frontal sinusotomy. And this on the right side, we had to do a right conchoplasty as well. And we could see the first draining from the right maxillary sinus. We also did orbital decompression as the patient presented with orbital involvement. So this was one of the cases with allergic fungal rhinosinusitis. In this also, we can see the hyperintensities which is caused by the heavy metals. This is again a similar case which is showing the hyperintense obesities in the left maxillary sinus, ethmoid sinus, and sphenoid sinus with involving only the left side. Again, we can see the hyperintensities which is caused due to the heavy metals presented here. We can easily appreciate in these slides. So treatment was endoscopic sinus surgery to remove all the inflammatory polyp, inflammatory tissue, polyp, and fungus. Here we can see the fungal debris coming out from the sinuses during the endoscopic surgery. So this patient was followed by postoperative topical steroids and nasal douching for a period of 3 months. So on follow-up, 2 patients with the AFRS was noted to have recurrence, and none of the bacterial meningitis patient had any recurrence. So coming into discussion portions, it's an it could be contributed to due to multiple factors such as local factors such as sinus obstruction, septal deviation, nasal polyps, adenoid hypertrophy, or foreign bodies. It could also be caused due to any inflammatory infective conditions or any systemic conditions such as immune deficiency, cystic fibrosis, or primary ciliary dyskinesia. So clinical presentation of these cases will be with persistent and non-improving nasal discharge or cough for more than 10 days. Double sickening is also seen in these cases, which means like there will be an initial improvement, which is followed by worsening of symptoms. And most of the cases doesn't need much investigation, but if we are suspecting any complication, we'll have to do a thorough investigations, which includes radiological, microbiological, and hematological investigations. So the complications of acute rhinosinusitis are mostly intra-orbital complications, which accounts for about 60 to 75%, and they're followed by intracranial complications, which account to about 15 to 20%, and osseous complications, which accounts to about 5 to 10%. So coming into orbital complications, it can be divided into 5 stages by Chandler's classification. So first stage is preseptal cellulitis, followed by orbital cellulitis, followed by subperiosteal abscess, followed by orbital abscess, and followed by the last stage, which is cavernous sinus thrombosis. And coming into intracranial complications include abscess formation, meningitis, cerebritis, and dural venous thrombosis. And local complications include osteomyelitis of the surrounding bone. And coming to allergic fungal rhinosinusitis, it is characterized by nasal polyposis, a type 1 hypersensitivity to fungal epitopes, very thick eosinophilic mucin, and peripheral eosinophilia. It is similar to the presentation in adults, but it will be more aggressive in pediatric cases with a higher serum immunoglobulin E and frequent bone erosion and malformation of facial bones. The mainstay of treatment is surgery followed by postoperative corticosteroids. We can also include topical or oral antifungal agents. Allergen immunotherapy may improve the outcomes in pediatric AFRS, but there is the evidence is limited. So coming into conclusion of our study, the complications of acute rhinosinusitis are rare and challenging, but the prognosis can be favorable. Early diagnosis and surgical drainage procedures in conjunction with aggressive medical management remains the standard of care. AFRS being characterized as a benign non-invasive disease, its presentation can range from simple nasal obstruction to signs and symptoms of intraorbital and or intracranial complication, with pediatric cases being very aggressive. So it requires a careful clinical evaluation, detailed histopathological examination, navigation-assisted endoscopic surgery, followed by steroid treatment and a lifelong follow-up to manage the recurrence. So these were my references, sir, and thank you, sir.
Atul, it was a good study, a nice topic to have been studied. I really liked it.
Thank you, ma'am.
Sir, any questions, sir? Nagaraj, sir? If no questions, the session will be ended here, sir. So thank you so much, judges, Dr. Nagaraj, sir, and Muthuchitra, madam.
Thank you, sir. Thank you, sir.
Thank you so much, sir. Sir. Thank you, chairpersons, Dr. Shekhar Reddy, sir, and Dr. Rakesh, sir. We'll go ahead with the second session, sir.
Okay.
Yeah. Next session, the judges are Dr. Anil, sir, from Bangalore, and Dr. Dinesh Rajendran from Bangalore. So welcome, sir. They may join. Dinesh sir already joined, I think. Anil sir will join in. Yeah. Welcome, sir. Sir, just 5 more minutes, sir. Anil sir is on the way. He will join session, sir. Dinesh sir.
Yes, sir. I'm here.
We will wait for 5 more minutes. So, sir will join. Once Anil sir joins, we will go ahead with the serial number 15 candidate.
Okay.
Rakesh sir, Rohit. Yeah. Tell the candidates 15 number onwards.
Yeah, it is Dr. Bhavana, 15th number.
Yeah.
Sir.
Be ready
Sir,
with
good
your
afternoon, sir.
presentation. Be
Yes,
ready
sir.
with your presentation. Once another judge joins, we'll start the session.
Okay, sir.
Yeah. So go through your slides. Any technical issues, please go through now itself. Sriharsha, are you there?
Yes, sir.
Meanwhile, I will send the CVs of our judges.
Okay.
Please read out. I will send just a minute. I will send. Sriharsha, because of technical issue in the morning, we couldn't read out the CV of Dr. Nagaraj sir and Muthuchitra ma'am. Please start that. I'm sharing the details now itself.
Okay.
Share the screen. Just Dr. Nagaraj sir, CV, and Muthuchitra ma'am also. Just read out and see. Sriharsha?
It's loading, sir. Just one.
Okay. Muthuchitra ma'am did send. Okay, you read out the Nagaraj sir CV. Convey our thanks. Anil sir.
Sure. So today we conclude session 1 of case series, and we are extremely thankful to Dr. Nagaraj sir and Dr. Muthuchitra ma'am for taking their valuable time and judging our first half of case series presentations. So I would like to briefly introduce Dr. Nagaraj sir. He is a resident of Bangalore, and he has done his MS ENT from Kempegowda Institute of Medical Science, and he has a total work experience of 15 years as a postgraduate examiner and undergraduate examiner. And he's also NABH coordinator of MBJ Institute of Medical Sciences. He also is credited with 9 research papers, and he has published in various international and national index journals. So thank you very much, Nagaraj sir. We hope to see you again in the future. And we will be moving on to session 2 of case series. And I welcome Dr. Rajendran Dinesh Kumar sir. We have been known to each other since almost 5 years. Hello, sir. Welcome.
Yeah, read out sir CV also.
Sir, yes, sir.
Just a minute.
Waiting for the CV of Anil sir.
I'll just be sending it.
If it is possible now, sir. Otherwise, after end of the session, also be read out.
I have sent already.
Yeah. Thank you, sir. Thank you so much. Yes. Yes, sir. Harsha, you can read out now. I have sent to you.
Sir.
I hope Harsha doesn't find it difficult.
That's why.
So, just a brief introduction of Dr. Rajendran Dinesh Kumar. He's also a resident of Bangalore, and he has done his MBBS from Mauritius in 2008, and his MS ENT from Navodaya Medical College, Raichur. And he presently is working as assistant professor in Rajarajeshwari Medical College, and he's also consultant ENT in Trustwell Hospital, Bangalore. He has a very vast experience in teaching ENT and head and neck for undergraduate students from 2012 to 2015, and he also has worked as a senior resident in Rajarajeshwari Medical College. To his credit, he has encouraged and published various research articles and he's also currently working on a few articles. And he has also received various awards in national conferences, like the Young ENT Surgeon of Karnataka 2018 in the 36th Annual State Conference, and also the prestigious RAF Cooper Award for Original Research in AOITSCON Kolkata 2017. With this brief introduction, welcome, sir, and please go ahead.
Thank you. Thank you for the opportunity.
So next candidate can start their
Harsha, just wait. Wait
Yes,
for Anil sir, Anil Kumar sir. He is also senior most faculty from Bangalore. Harsha, 2 minutes. Rohit. Sriharsha.
Sir.
సార్ది కూడా CV ఒకసారి రీడౌట్ చేయమా పంపించాను.
ఓకే.
అనిల్ కుమార్ సార్. అంటే చాలా పెద్దది. Just
briefly read out.
Yeah, you can brief it out. You can display there. You can share the screen and read the important thing.
We welcome Professor Anil Kumar, sir, who has done his MS ENT from Father Muller Medical College in 2007 and also as a Rhino-orbital fellowship from South Korea. He has been into government service since 1997 and with total professional experience of 25 years. And he has worked as an examiner for postgraduates and undergraduates for various universities in India, and he's also a member of assessor of National Medical Commission for postgraduates. With this short introduction, I would like to welcome Professor Anil Kumar sir.
Before going to the session, I would like to invite Dr. M. Vishnuvardhan Reddy sir. He's a former retired professor from Uspana Medical College. He is also retired superintendent of Government ENT Hospital. Dr. M. Vishnuvardhan Reddy sir, welcome to the session and chair this session. I request you to chair the session. Vishnuvardhan Reddy sir. Those candidates who have finished their presentation can left from this link and can watch from the YouTube link. Sriharsha?
Ramesh sir?
Yeah. Rakesh sir?
Sir?
ఒక్క నిమిషం సార్ జాయిన్ అవ్వగానే చేద్దామని
ఓకే సార్.
ఒక 1 to 2 minutes లో జాయిన్ అవుతామని మెసేజ్ చేశారు. అయితే ఇందులో ఇప్పుడున్న 15 క్యాండిడేట్ నుంచి 29th వరకు ఉన్నాయి కదా, అందులో 28th నెంబర్ అక్రమునిసా షీ మెసేజ్ మీ నాట్ ప్రజెంటింగ్, 28 absent.
28
only 14 members left. Remaining 14 members start చేద్దాం.
ఓకే సార్.
జస్ట్ ఐడియా కోసం చెప్పాను. 28th నెంబర్ ఉంది కదా అక్రమునిసా.
ఓకే సార్.
అనిల్ సార్ కాల్ చేస్తారు. Yeah, welcome Dr. Anil Kumar sir. Yeah, we will start our sessions. Yeah, you go ahead sir. Rakesh sir.
Next presenter, Dr. Bhavana. Please share your screen, Amma. Bhavana.
Sir, good afternoon, sir.
Good afternoon.
You go ahead, Amma. Yeah, you are audible. Join with your video. Without video.
1 minute, sir. Yes, sir.
నేను ముందే చెప్పాను స్టార్ట్ చేసుకోండి. ఓకే.
Sir, am I visible, sir?
Yes.
Good afternoon, sir. My name is Dr. Bhavana. Today my topic is comparison of preoperative high-resolution computed tomography findings with intraoperative findings in patients with cholesteatoma. Introduction. Cholesteatoma is defined as a sac of keratinizing stratified squamous epithelium in the middle ear cleft containing desquamated epithelium keratin debris. It is the end stage of squamous epithelial retractions of pars tensa and pars flaccida that are not self-cleansing and retaining epithelial debris. Propensity and invert the middle ear and the mastoid posteriorly and finally to erode the temporal bone. Cholesteatoma can be congenital or acquired. Acquired cholesteatoma can be primary or secondary. Cholesteatoma leads to malodorous discharge when it becomes infected. Recurrent or persistent ear discharge is a feature of cholesteatoma. Cholesteatoma also presents with earache, hearing loss, dizziness, or tinnitus. Lateral epitympanic wall, scutum, is the first to be eroded in the cholesteatoma, which extends into adytus and antrum posteriorly, followed by ossicular chain erosion. The lenticular process of the incus and the superstructure of the sapes are commonly affected. High-resolution computed tomography of temporal bone is now considered the most useful radiological imaging modality in demonstration of bony details in the temporal bone and soft tissue density in the middle ear and the extension of the pathology into the cranial cavity. The hallmark of cholesteatoma is bony destruction on high-resolution computed tomography imaging. Aims and objectives: to study the role of high-resolution computed tomography in patients with cholesteatoma, to determine the extent and the site of cholesteatoma and its sac, assessing the ossicles and ossicular chain status, evaluating the facial nerve canal, the tegmen and the sinus plate, evaluation of dura, sigmoid sinus and the jugular bulb. To compare the above with intraoperative findings and proceed the surgery accordingly, so as to avoid complications intraoperatively and for the better outcome. Materials and methods. Subject selection. Subject selection was carried out in the outpatient department of ENT. Type of study. It was a prospective comparative study conducted over a study period of 12 months with a sample size of 50 patients. Inclusion criteria. Both male and females were included. All the patients diagnosed clinically as chronic suppurative otitis media with acquired cholesteatoma, and the patients presented with chronic ear discharge. Exclusion criteria. Patients with a history of previous ear surgery, patients with history of radiotherapy to head and neck, patients with tumors of temporal bone. Methodology. Patients with cholesteatoma presenting to ENT outpatient department were taken up for the study. Detailed clinical history, pathological examination, endoscopic examinations were carried out. Routine laboratory investigations were done. Then all the patients were subjected to high-resolution computed tomography of temporal bones, 1 mm axial and coronal slices. Once the radiological findings were noted and the extent of the disease was established, management was done accordingly. The age of the patients ranged from 9 years to 55 years were included in the study. There were 27 males and 23 female patients. Majority of the people were in the age group of 9 years to 36 years. Observation and results. Sputum erosion, which was visualized in majority of the patients out of the 50 patients. Here you can see sputum erosion on the right side on HRCT imaging and the endoscopy picture showing right attic region cholesteatoma. Incus appeared eroded on CT scan in 23 cases, which is around 46%, whereas intraoperatively it was seen in 25 cases. Malleus erosion was reported in 10 cases, which is around 20% of the cases on CT scan, whereas intraoperatively it is seen in 13 cases, which is around 26%. And occupying whole of the middle ear cavity is seen on the right side, on the left side of the HRCT scan, whereas the intraoperative picture showing erosion of all the ossicles. Below scan, in the HRCT scan, you can see soft tissue density in whole of the mastoid region involving the mastoid and the antrum region. Intraoperative picture showing cholesteatoma mass in the mastoid antrum. Facial canal erosion was depicted in 3% of the cases by CT, whereas intraoperatively it was seen in 2 cases. Erosion of lateral semicircular canals was reported in 5 patients intraoperatively and on CT scan. Sigmoid plate erosion was seen both on CT scan and during surgery in 3 cases, which is around 6%. In HRCT, soft tissue density seen in the mastoid antrum involving whole of the mastoid cavity with the erosion of sigmoid plate. On the right side, there is anterior lying sigmoid sinus. High jugular bulb was seen in 2 cases, which is around 4% of the patients, both in CT scan and during the surgery. Discussion. HRCT is considered as the imaging modality of choice for the anatomical and pathological evaluation of temporal bone prior to the surgery, including chronic otitis media, that is cholesteatoma. In this study, incus was most commonly affected ossicle, followed by malleus and stapes. The sensitivity of HRCT for detecting malleus erosion was 83.3%. Incus was around 92.5%. These findings were inconsistent with the findings of the study conducted by Chi et al. Sputum erosion was visualized in majority of the patients in our study. Jackler et al. Found cholesteatoma to be present in around 40% of the cases with bony erosion that were explored in the study. It gives precise information about the location and the extent of the disease, the status of the ossicular chain erosion, erosion of lateral semicircular canal, and the fallopian canal also be well appreciated. The sinus tympani and the facial recess, which are known as hidden areas, can be easily identified on the high-resolution computed tomography of temporal bone scan. The delineation of the pathology prior to the surgical exploration allows the operating surgeon to plan the most appropriate surgical approach that is required for the better outcome. Conclusion. The results of this study suggest the preoperative high-resolution computed tomography imaging in case of cholesteatoma, ossicular chain erosion, and semicircular canal dehiscence have good correlation with the intraoperative findings. HRCT can act as a guide to the nature of disease, potential dangers, and possible complications, and this information can assist the surgeon in the choice of surgery to be performed for the better outcome of the patient. These are my references. Thank you.
Madam, your young patient was 9-year-old. So what
Sir,
difference?
age group.
Huh?
Sir?
Age group was from 9 years.
Sir, yes, sir. Age group from 9 years to 55 years, sir.
Yeah. So in that pediatric age group, have you correlated any findings?
Sir, mostly pediatric cases were normal, sir. Just we have included in the age group section, sir. Mostly they were seen between 18 to 25 years age group people were very common.
Pediatric age group, how does the cholesteatoma behave?
It was with intact tympanic membrane, sir. There was a bulge behind the intact tympanic membranes.
My question is, how does cholesteatoma behave in pediatric age group?
Sir, it was a...
Any difference when adult and pediatric cholesteatoma?
Sir, there was a difference regarding the tympanic membrane appearance, sir. There was no associated perforation seen in the pediatric age groups, sir. There was a bulge seen behind the tympanic membranes, sir. Mostly they were presented with the ear pain and...
No. Okay. If sir wants to ask some questions.
Okay, presentation was good, and you have just given important salient features. Can you tell us the reason? Can you tell us the reason why is incus the most common bone to undergo necrosis?
So there is a single artery supply, sir, and there is a single ligament to hold for the support, sir.
Okay. Any other points?
Osteoclastic activity is more than osteoplastic activity in the incus, sir.
Okay. See, in your study, as sir had mentioned, what is the characteristic features which differentiate adult cholesteatoma from pediatric cholesteatoma? If you have answered this question, you will understand how aggressive the conditions are in pediatric cases. So, can you summarize what exactly you want to take home? Do CT scan correlate with the intraoperative picture?
Sir, even if there is a mucosal type of disease, sometimes you can see the mastoid antrum filled with the granulation tissue or the cholesteatoma intraoperatively. So better to advise a scan before to know the status of the patient and the bony pathology or the anatomy of the bone before planning for the surgery, sir.
So you recommend HRCT for all cases?
Yes, sir. For the soft tissue to delineate the correct characteristics of the soft tissue densities present in the cavities.
Okay.
Erosion of ossicles can be easily delineated, sir.
Okay. I think you have some backup support talking and helping with you. Kindly avoid such things. You are on your own to present when you are presenting in a online session. Okay. Other students can keep in mind, right? And thank you. We can move to the next presentation.
Next presenter.
Sir, am I audible, sir?
You are audible. Share your screen.
Sir, I think the timings are 8+2 or 6+2.
7. Total time is 8 minutes, sir.
Okay. Fine.
8 minutes. 7 we'll have first.
Then okay. Okay.
You can start, madam.
You will start presentation. Just share your screen.
Yes, sir.
Yeah. If you are unable to do, we'll go to the next candidate. You can come back at last.
Okay, sir.
Yeah, next candidate. Who is the next presenter? Dr. Bushra.
Good evening, sir. Sir, good evening, sir.
Yeah. Just share your screen.
Yes, sir. 1 minute, sir.
Rohit, you can just tell which number is presenting so that we can give marks. I
Now
think
17 number, sir.
17.
Number 17.
Okay. Okay. Good.
Dr. Bushra Azmat.
Yeah.
Yeah, you can start.
Can you go to your first slide? Yes. Thank you.
So, my topic is a comparative study of occlusive nasal packs and internal nasal splints after septoplasty. Introduction. Septoplasty is one of the most common operations in otorhinolaryngology. Nasal packing is used primarily to control bleeding in all endonasal surgeries. Packing also facilitates internal stabilization following operations on the cartilaginous and bony skeleton of the nose. Packing also helps in preventing complications like hematoma, infection, abscess formation. But some complications like mucosal injury, sleep disturbances, aspiration of various packing materials, eustachian tube dysfunction occurs with nasal packing, which questions the wisdom of using this type of packing method. The aim of this study is to compare the postoperative results of regular nasal packing with that of transnasal septal splints. Materials and methods study design a comparative study in which 80 patients were studied during the period of 12 months. Inclusion criteria: all patients with deviated nasal septum between 18 to 60 years age group were included. Exclusion criteria: patients with history of previous septal or turbinate surgery, patients using hemodiluting agents, patients with history of nasal polyposis, drug abuse, patients with bleeding diathesis and other medical disorders. Methodology: patients were divided into two groups, Group A and Group B. In Group A, silicone septal splints were placed, fixed by 8-shaped transseptal sutures with 3,0-ethylene suture material, which were removed after 1 week postoperatively. In Group B, regular nasal packing was done, which was removed after 48 hours postoperatively. And both the groups were followed up regularly at first week, third week, and second month postoperatively. So this is the video wherein transnasal septal splints are placed. First, suture material is passed through the splint, secured with a knot. Then the suture material is passed transseptally in the posterior aspect of septum, then through the anterior part of the septum. Then the splints are placed into both the nasal cavities. Splint kept in one nasal cavity and then other nasal cavity, and then secured tightly with a knot. This is the video showing removal of splints in the same patient 1 week after surgery. Results. The demographic characteristics of patients subjected to septoplasty. In the first graph, we can see that the age group between 20 to 29 year people are more in both the groups, group with intranasal splint and group without splint. And in the other graph, you can see that there is female predominance in both the groups. Early postoperative outcomes contrasted between the two included study groups. First is postoperative pain level, which is seen more in the group without splints. Then sleep disturbances and difficulty with food intake is seen more in the group with intranasal splints. Late postoperative outcome like adhesions, crustation and perforation is again seen more in the group without splint. Discussion, our study showed decreased risk of adhesion between septum and turbinates in the splint group. Schonberg et al., Campbell et al. Also showed the same thing. Our study showed sleep disturbances more in the splint group, whereas Abdul Khalik and Jung et al. Showed no variation in sleep disturbances in splint group. Our study showed decrease in rate of crustation. Similarly, previous studies showed decreased rate of crustation in splint group. And there is no incidence of septal perforation in splint group, and it is in line with the previous studies. Our study also showed decreased postoperative pain in the splint group when compared to non-splint group, which is similar to previous studies. Conclusion, septal splint suturing results in less pain and discomfort for the patient, and there is also decreased incidence of crusting and adhesions. So based on these observations, the septal splint suturing technique is a valid alternative to intranasal packing following septal surgery. These are my references, sir. Thank you.
Madam, is respiratory distress any side effect of any type of
The nasal
this,
packing will lead to respiratory
splint
distress
or
in process.
which can cause respiratory distress?
Nasal packing, sir.
How about transseptal suturing?
Sir, some patients complained of sleep disturbances. It is more in the intranasal splint
Not
in my
sleep
study, but
disturbance I am talking about, respiratory distress.
respiratory distress is not seen with splint, sir.
What
It
is the
is seen with
relevance,
nasal
any
packing.
comparative between smoking and non-smokers?
Smokers and non-smokers? Sir, I didn't get your questions.
Have you taken smoking into consideration? Have you asked that history? Was there any difference?
Sir, if there is any history of smoking, recent smoking history, we didn't go for operation. We have stopped at least for 10 days or 48 hours or so, sir.
Normally,
Before
you do
operation.
that? Everyone does that? Or only for your study you did that?
No, sir. Normally, for every case, we do that, sir.
Okay.
So, doctor, the presentation was concise, good. But what exactly do you want to prove? Just that you've done in your video, you've done a quilting stitch, interseptal quilting stitch, and then you have placed an internal nasal splint, which is a silicone splint, correct? And you have removed it on the 7th day. When you're comparing with intranasal, nasal packing material. What other methods you can do to ensure that there is no such incidence of you're comparing synechia formation or crusting or adhesions, but what better method you can follow if you are doing occlusal pack? Can you put a gloved occlusal pack, like a gloved nasal
Yes,
pack?
sir. Yes, sir.
Okay. So because
We can also go for
yeah,
Mirocell.
yes. So
Sir.
if you are using the intranasal splint, there will also be some amount of obstruction. It may, if you have corrected well the deviation, it's fine. But occlusional plaques, what else do they cause? What do they cause? They can cause stasis of secretions and again blockage
Yes,
in
sir.
the level of
Nasal
osteometal
obstruction.
complex, which can lead to persistent of nasal complaints. Okay. So
So
quilting stitch is a better option, or a septal splint is a better option. But what is your what is the novelty in this method? Because we
I
know
think
already at this point.
it's the packing. There is more of discomfort to the patient. There will
What
be complete closure of nasal cavities. Nasal obstruction will be there for 48 hours. So that discomfort can be removed by using splints.
Okay.
And we can also
All right.
make sure that the deviated part is again supported by it after surgery to make the septum straight.
Okay, fine. Thank you.
So,
Yeah.
and
Next presenter, be ready with your presentation.
Good afternoon, sir. Am I audible?
Yeah, you are.
Good afternoon, sir. I am Dr. Meghana Nandipati. My case series is external auditory canal mass, a case series of squamous cell carcinoma of temporal bone.
Yes. Your screen is not clean. Just wait.
1 second. Is it visible, sir?
No.
Yes, sir.
It's not visible. It's not visible.
Yes, sir. Yes, sir.
If the
Yes, sir.
now we can see.
Yes, sir. Good afternoon, sir. My presentation is on external auditory canal mass, a case series of squamous cell carcinoma of temporal bone. Temporal bone squamous cell carcinomas are extremely rare and comprise 0.2% of all tumors of head and neck. They originate primarily from the external auditory canal, middle ear, mastoid, and petrous apex. Ear pain, ear discharge, signs and symptoms that may mimic otitis, cholesteatoma, and polyp are the most common early manifestations of the disease. Importance of this disease lies in that it is quite aggressive and there is difficulty in tackling this disease due to its inaccessibility as it is present in the temporal bone. Aims and objectives. My aim is to present a series of 4 cases of squamous cell carcinoma of the temporal bone, which are presenting as external auditory canal masses, and an overview of the management. Materials and methods. The study approach was a review of 4 patients with external auditory canal masses in a tertiary care hospital who were subjected to detailed clinical history and examination. Radiological and histopathological investigations were done and treatment was offered to them accordingly. So this table shows a summary of all the patients which we are going to discuss. Case 1 is a 44-year-old female who presented to the OPD with blood-stained ear discharge and a fungating mass protruding from the right ear and 3 ipsilateral palpable lymph nodes in level 2 and level 3 lesion. Autoendoscopic guided biopsy was done and histopathology showed well-differentiated squamous cell carcinoma. HRCT temporal bone was done to assess the extent of disease and for surgical planning. The patient was in stage 4 with a T3N2B M0 lesion. So this is the CT scan showing the extent of the disease. The patient underwent right lateral temporal bone resection plus superficial parotidectomy and selective neck node dissection, and the tumor was removed en bloc. Post-operatively, the patient has developed grade 4 facial nerve palsy, and on follow-up, ultrasound neck revealed metastatic deposits. Patient was referred to radiation oncologist for further radiotherapy. So this image shows a craniotemporo cervical incision, and this shows a selective neck node dissection being done. And this is the superficial parotidectomy and the vertical segment of facial nerve following into the parotid. And this is the tumor which was resected en bloc. Case 2 is a 60-year female presenting with bloodstained left ear discharge in the left external auditory canal. Otoendoscopic biopsy revealed a moderately differentiated squamous cell carcinoma, and the CD temporal revealed an early T2 lesion. She was advised surgery, but she refused. However, she opted for post radiotherapy. She tolerated the treatment well with significant resolution of the mass. Radiotherapy was given with 65 grays over a period of 7 weeks. Later, she developed left auricular and post-auricular region wound infection. Pus for culture sensitivity was sent, and patient was treated with IV injection piptaz 4.5 grams BD for 11 days. Case 3, and the patient has recovered well from the infection. Case 3 is an 82-year female who presented to the OPD with left ear discharge. Otoendoscopy revealed a pinkish mass with granular surface filling the EAC and which was friable and bleeding on touch. The case was initially diagnosed as left chronic otitis media with oral polyp. HRCT was done to assess the extent of disease and for surgical planning. The patient underwent canal wall down mastoidectomy with complete resection of the mass under GA, and the specimen revealed a moderately differentiated squamous cell carcinoma. She was advised post-operative radiotherapy. Case 4 is a 65-year female presenting to the OPD with complaints of right ear discharge and pain during mastication. Otoendoscopic biopsy revealed a well-differentiated squamous cell carcinoma of the external auditory canal. HRCT temporal revealed an extensive mass involving the right external auditory canal, middle ear mastoid auricle extending into the temporomandibular joint with destruction of squamous and temporal part of the temporal bone, which was suggestive of a malignant disease. No palpable neck nodes. It was a stage 4 disease at T4N0M0 lesion. Patient was advised surgery, but she refused. She opted for concurrent chemo and radiotherapy. Unfortunately, the patient has succumbed to the disease shortly after starting the treatment. For discussion, the common predisposing factor for all these patients in this series was their past history of chronic otitis media, which they had since childhood. All patients presented with non-specific signs and symptoms, most common of which is ear discharge, mass in the external auditory canal, and other associated headache, ear pain, pruritus, and hearing loss. Surgery is still the cornerstone of treatment for this malignancy. Surgical resection with negative margins, followed by concurrent chemoradiotherapy, is sought to be followed in all the cases. However, radiotherapy with or without surgery is the treatment of choice for patients with T1 and early T2 disease who are not willing to undergo surgery or not medically fit for surgery. In this series, 2 patients underwent surgical treatment and post-op radiotherapy, while 2 refused surgery. One was compliant with radiation and able to achieve a stable disease, and other has succumbed to the disease. Due to rarity of the disease, adequate staging system has not been developed, and we are currently using the Pittsburgh staging system. The standard of care for management of temporal bone squamous cell carcinoma, there are 3 options for resection, which are the lateral temporal bone resection, subtotal temporal bone resection, and total temporal bone resection. All these procedures take advantage of anatomy of the temporal bone in establishing tumor-free margins, and they can be offered accordingly, according to the extent of the disease and how well the patient is able to tolerate the procedure. Radiotherapy is commonly given in the adjuvant post-operative setting. However, it can be given as a primary modality in T1 and early T2 lesions. Indications for radiotherapy are lymph node involvement, perineural invasion, positive margins, and recurrent tumors with bone invasion. Incidence is very rare of 0.2% in all head and neck tumors. 1 in 1 million is noted. And the known risk factors are chronic otitis media, chronic otitis externa, patients with prior radiotherapy for nasopharyngeal carcinomas, habitual ear picking, and other like HPV and sun exposure. There may be a delay in diagnosis of up to 13 months, which is usually due to non-specific symptoms and signs which mimic inflammatory ear disease. Early diagnosis and high index of suspicion cannot be overemphasized in this disease. Due to aggressive behavior of this disease, radical treatment with combined modality and vigilant surveillance should be employed. My take-home message from this series is that whenever we are treating a temporal bone squamous cell carcinoma, the cornerstone of management is surgical excision with negative margins followed by definitive radiotherapy. And for early T1, T2 lesions, we can go for a only primary modality as radiation. And also, all the patients who are presenting with oral polyp, they can undergo initially
One more
a
minute to go.
preoperative biopsy. Yes, sir. They can undergo a preliminary biopsy in the preoperative period to know about the benign or malignant nature of the mass. And finally, advanced radiotherapy is not a very preferable mode of management for advanced lesions like T3 or T4 lesions. These are my references. Thank you.
Madam, when you can say the patient has got very good prognosis?
So when the patient has been diagnosed very early in the stage of disease, like in T1 or early T2, which is the mass is involving only the external auditory canal, sir, not involving up to the middle ear or mastoid, or there is no lymph node or distant metastasis, then the patient can have a very good prognosis.
No involvement of bone.
Yes, sir. No bony involvement or middle ear involvement, sir.
How many cases had facial weakness?
No, sir. These cases which were presented to our OPD, they did not have any facial nerve palsy, sir.
Any relevance?
Yes, sir. Facial nerve palsy is indicates perineural involvement with bony erosion. So it has got a relatively poor prognosis, and the management will also involve. We can like completely resect the facial nerve while doing. There is no need to preserve the facial nerve while we are doing a lateral temporal bone resection.
On follow-up, what investigation you want to do?
So for follow-up, I want to follow the patient initially every 3 months, sir, and later annually after 2 years. So in the post-operative follow-up, first I would like to go for a auto-endoscopy to see if there is any recurrence of the disease. And if there is no recurrence of no evidence of any disease, then for further investigation, we can go either for a HRCT temporal bone or MRI or PET CT, sir.
No, not all three, madam. You should tell one.
So first I will go for an
PET,
auto-endoscopy.
why PET?
Yes, sir. Sir, PET CT is the best modality of
No,
management,
no,
but if
no,
it is
no,
not
no.
available,
No.
but if it is not available, we can go for a HRCT or MRI, sir.
No. Okay, thank you. Sir, will ask.
Okay. Very well presented to the point.
Thank you, sir.
See, when you're answering question, you can answer to the point. It will help us and also help you.
Yes.
My question to you is, can you name any tumors which metastasize to the external auditory canal? Because you're all mentioning this as primary. Can
Yes,
it be
sir.
a secondary? Can you name any tumors? Because you have just mentioned only 4 cases.
Yes, sir. Yes,
you mentioned its rarity.
Yes, sir.
But can you mention any tumors which metastasize to the ear canal?
Mostly we can go for basal cell carcinoma or malignant melanoma of the pinnas. They are due to their close proximity. Maybe they can invade the canal skin, external auditory canals.
You didn't understand my question, doctor. Suppose there is a primary somewhere.
Yes, sir.
Where such tumors can you give some example of a different primary which can metastasize to the ear canal? You're understanding?
No, yes, sir. I have understood your question, but I
Ah.
don't have an idea regarding
Okay.
this.
So colorectal carcinoma, breast carcinoma, some of them have presented as external auditory canal lesions. So you were mentioning something about PET scan and all those things.
Yes,
See,
sir.
PET
Yes, sir.
scan is when you are having a diagnostic dilemma and also when you are prognosticating and following up your cases.
Yes, sir.
If you have treated a primary and you are waiting for the response following chemotherapy or radiation therapy,
Yes,
you
sir.
can follow it up very annually once to check whether there is any recurrence.
Yes, sir.
So you presented a rare case, good photographs, good images. Okay, so thank you. Okay.
Thank you, sir. Thank you, sir.
Next presenter.
Am I audible, sir?
Yeah.
Just a minute, sir. I'll just adjust my screen, sir.
Next speaker, next presenter.
Yes, sir. I'm sharing my screen, sir.
You are Dr. Madhumita.
Yes, sir. I'm Dr. Madhumita, sir. I'm sharing my screen, sir.
Dinesh, sir, number is 19.
Sir, can you see my screen, sir?
Yeah.
Just a minute, sir. Just a minute. Yeah.
One candidate, I think number 16 has not
Yeah,
presented.
she'll come back at last, sir.
Okay.
Sir, can you see my screen, sir?
Yeah, go ahead.
So my topic for case series is surgical management of photogenic skull-based osteomyelitis, our experiences, sir. I can't change my, sir, I can't change my slide, sir. Can you say the change in slide, sir?
No, I also don't.
Just a minute. Okay. Just a minute, sir. Yeah. Now is it visible, sir?
Yeah, it is visible.
Okay, sir. Yeah. Melzer and Kellerman in 1959 first described skull-based osteomyelitis of photogenic origin. It is a life-threatening condition with underlying comorbidities and in elderly. It has a mortality of 46% and morbidity of 31%, sir. It involves temporal bone and presents with symptoms of excruciating ear pain, discharge, and cranial nerve palsies, and hence is referred to as malignant otitis externa, which is a misnomer. The aim of the study is to establish importance of surgical intervention in otogenic skull-based osteomyelitis. We conducted a prospective study in our center from August 2022 to August 2023. We had come across 11 confirmed cases of malignant otitis externa, of which 5 were managed conservatively and 6 were intervened surgically. Age, gender, medical history of the cases were recorded. All patients underwent thorough clinical examination and cases were divided into medial, lateral, and pan-temporal bone osteomyelitis. After confirmation, relevant investigations were done, like protein blood investigations, pus for culture sensitivity, biopsies from granulation tissue for histopathological examination, HRCT temporal bones, and contrast enhanced MR. In my subject group, most of the patients were male, and most of the patients fell between 40 to 50 years of age. General condition of the patients were evaluated. One patient did not have any comorbidities. The rest 10 had overlap of comorbidities. 7 had uncontrolled diabetes mellitus, 2 presented with anemia, 1 was immunosuppressed, and 1 had renal failure. Presenting complaints, ear pain was the most common complaint among patients in 8 of the patients. 4 patients had cranial nerve involvement. 5 patients did not have any cranial nerve involvement among our subjects. 2 had single cranial nerve involvement, that is 7th nerve, and the rest of the patients have multiple cranial nerve involvements. 7th or 8th was consistently present, and 2 had involvement of 9th, 10th, 11th, and 12th complex. And in 1 patient, there was involvement of 5 and 6 as well. This shows the Chandler's classification of malignant otitis externa, and based on this Chandler's classification, the subject group was divided into 4 stages. Clinical evidence of malignant otitis externa present in 27% of our subjects, with a technetium 99 scan positive in 27% again, and single nerve involvement was seen in 9% of subjects, and multiple cranial nerve involvement in 37% of subjects. Stage 4 was seen in no cases. On examination of ear under microscope, granulations was the most consistent finding in 11 cases, edema of sac in 6 cases. There was otomycotic debris in 1 case. Exudate from the external aortic canal was sent for culture sensitivity. Pseudomonas aeruginosa was the most common organism isolated in 6 cases, followed by Staphylococcus aureus in 3 cases, Klebsiella pneumonia in 1 case, and Aspergillus niger in 1 case. HRCT temporal bones showed automatosteroiditis as a consistent finding in all the 11 cases. Erosion of fallopian canal was seen in 3 cases, petrous apicitis, and erosion of clivus in 2 cases each. This is a HRCT temporal bone image of one of the subjects of our study, which shows erosion of the petrous apex, basis sphenoid, and clivus, and also erosion of tympanic part of facial nerve. Gadolinium enhanced MR was done, and marrow edema was the most consistent finding in all the cases. Meningeal enhancement was seen in 3 cases. This is a contrast MR image of one of our patients, which showed marrow edema involving the right-sided basis sphenoid, basi occiput, petrous mastoid portion of right temporal bone, partial loss of flow void in cervical, petrous parts of right internal carotid artery. The patients were classified according to the part of the temporal bone involved into pan-temporal bone osteomyelitis in 1 patient, that is 9% of the cases, lateral temporal bone osteomyelitis, which was majority of the cases, that is 64%, and medial temporal bone osteomyelitis in 27% cases. IV antibiotic therapy, empirical therapy by anti-pseudomonal antibiotics like ciprofloxacin, piperacillin, tazobactam, vancomycin, and imipenem was administered as a non-surgical method, preferably after culture sensitivity. Option of hyperbaric oxygen was not feasible at our center, and patients was not responding to conventional treatment, and those with petrous bone involvement and sequestrum on scan were intervened surgically. Surgical options we had were local debridement, canal wall of mastectomy with or without facial decompression, subtotal petrosectomy with blind sac closure of AAC. As patients were unfit for general anesthesia, most of them were operated under local anesthesia or monitored anesthetic care. This slide shows the steps of subtotal petrosectomy with blind sac closure. First slide shows the incision, which is taken 2 centimeters beyond the postoral groove, followed by a blind sac closure of EAC. Then we proceeded on with canal wall, intact canal wall mastectomy, and then intact bridge mastectomy. Following it, IC was identified, and anterior to it, petrous bone was identified, and pus pockets in the petrous bone were drilled out, and the cavity was obliterated with abdominal fat. The management briefly goes by: 5 patients had medical management, 2 patients with canal wall up mastectomy with or without facial decompression, and 4 patients had subtotal petrosectomy with blind sac closure. Patients were followed up regularly between 10 to 14 days. We call the patient the suture removal, and they were followed at 1, 3, and 6 months respectively by clinical and otoendoscopy. 4 patients lost to follow-up. After subtotal petrosectomy, patients were offered hearing solutions by cross-hearing aid or Microtia implant, but they did not take it up. This is an image of one of the patients showing suture removal on 10th day and post-op follow-up at 6 weeks. Age of presentation in my study was between 30 to 70. 40 to 50 was the maximum patients falling into it. Male more than female, and common presenting complaint was excruciating nocturnal ear pain. Cranial nerve involvement was seen in 36% of the patients. Granulation was seen in 63%, and histologically it was confirmed as chronic inflammatory infiltrate. Pseudomonas was most commonly involved organism in 45%. Patient managed surgically showed no remissions of the disease, and immediate pain relief was better when compared to those managed medically. As a part of discussion, osteomyelitis of temporal bone is extremely rare, and we must hold a suspicion in patients with severe otalgia who have associated uncontrolled diabetes mellitus and also otitis externa refractory to standard therapy. Bacterial cultures with antibiotic sensitivity and targeted therapy is important, and whenever you see a sequestrum on CT scan and no response to conventional therapy, surgical intervention is a must. So why this study? Skull-based osteomyelitis is more prevalent these days due to poor diabetic control and also improved diagnostic modalities. So even though it is considered as a medically managed disease, the trend is shifting towards surgical involvement, and subtotal petrosectomy blind sac closure is employed. So we also emphasize importance of strict diabetic control. These are my references. Thank you.
Madam, you had 11 cases.
Yes, sir.
What are the cause for this? Like, what was the root cause? Did you evaluate?
Yes, sir. All my 11 cases were otogenic in origin. Thus, all the 11 cases were typical skull-based osteomyelitis, sir.
Okay.
Well presented.
Thank you, sir.
Slides were pretty impressive, and you have marked all the impressions. What are the structures that makes it very easy for anyone to review. What was the treatment duration for most of your patients? How long was the treatment duration?
Sir, conventionally, we treat the patients for 4 weeks, sir, with antibiotic therapy, but more than 1 to 2 weeks of refractory to antibiotic therapy, we employed for surgical intervention in our studies.
So only those not responding to antibiotics, you took them surgically, or there were any other measures?
No, sir. Also, the patients who had sequestrum on CT scan with pan-temporal and medial temporal bone involvement, we had gone for surgical interventions.
What is your limit for subtotal petrosectomy?
80% of the petrous bone has to be excised, sir. That is the limit.
Now, if you know, there are different type of pneumatization for the petrous apex. Was this a favorable? How many were favorable and how many were unfavorable?
Sir, can you please repeat the question, sir?
When you are doing petrosectomy,
yes, sir,
there can be pneumatization in the petrous apex. Okay, sometimes it can be even sclerosed.
Yes, sir.
Which are the cases which have favorable outcomes, and which are the cases you'll have unfavorable outcomes?
So in my study, whichever cases we've opted for subtotal petrosectomy had petrous bone involvement, sir. There were pus pockets in the petrous bone. So it was not a big challenge while operating, sir, because it was diseased bone and it was removed, sir.
Okay, can you name any 3 approaches for surgical approaches for petrous apex? Can you name any 3? It is there.
Transmastoid approach, sir.
No, I know. I need the names. It is there in your books. Okay.
Sir?
Almore's approach. If I've given you a hint, one.
Yes,
There
sir.
are, in cochlear approach, anterior. There are some. There are names, and there are 6 names to 6 surgical approaches to petrous apex.
Okay, sir. I will once read, sir. I'll read and I'll come back, sir. I exactly don't know exactly, sir.
Okay, fine. Good.
Thank you, sir.
Next presenter.
Thank you, sir. I stopping the video, sir.
Next presenter, Dr. Harika.
Sir, good evening, sir. I'm sharing my screen, sir.
Yeah.
Good evening, sir. My topic is assessing the use of Mitomycin C in preventing postoperative synechiae after endoscopic sinus surgery. Introduction. Rhinosinusitis is inflammation of mucosa of one or more nasal sinuses with associated changes in the nasal cavity. Functional endoscopic sinus surgery was originally designed to address obstruction in the osteomyelitis complex. It has been fully accepted as the choice of treatment for the chronic sinus disease. Though there are advances in instrumentation and surgical technique, postoperative adhesions and osteal stenosis represent a potential cause of surgical failure. Mitomycin C is an alkylating antineoplastic antibiotic that prevents replication of fibroblasts and epithelial cells. Aim of the study. This study is to assess whether topical application of Mitomycin C is useful in preventing synechiae formation and osteal stenosis following endoscopic sinus surgery. Materials and methods. Study design. A prospective comparative study is carried out in the Department of ENT with sample size of 30 patients during the period of 12 months. Ethics approval and consent from the patient to participate are taken. Patients are divided into Group A and Group B randomly. In Group A, 15 patients were studied with topical Mitomycin C application. In Group B, included 15 patients without using Mitomycin C. Inclusion criteria. Patients with features suggestive of bilateral chronic rhinosinusitis with or without nasal polyps willing to undergo CTPNS and endoscopic sinus surgery were included in the study. Patient aged between 18 years and 50 years are included. Exclusion criteria. Age below 18 years and above 50 are excluded. Patients with revision surgery and with acute exacerbation of symptoms, established asthma, suspected cystic fibrosis, and known systemic disorders are excluded from this study. Methodology. All patients were subjected to routine hematological test, diagnostic nasal endoscopy, and non-contrast CT scan of nose and paranasal sinuses with 1 mm coronal and axial cuts. The amount and location of sinus disease present determines the extent of the sinus surgery performed for each patient. One vial contains 2 milligrams of Mitomycin C, which is diluted with 2.5 ml sterile water to obtain 0.8 milligrams per surgery. In Group A patients, a cotton pledget saturated with Mitomycin C was applied in both right and left middle meatus for a period of 5 minutes. Then cotton pledget was removed and packed with Merosil. In Group B patients, after the surgery, nose is packed with saline-soaked Merosil. Mitomycin, this is an intraoperative video of Mitomycin C application after middle meatal antrostomy in right maxillary sinus. And this is the maxillary sinus ostium after post-Mitomycin C application. Observation and results. A total number of 30 patients of bilateral chronic rhinosinusitis with or without cyanonasal polyps were taken for the study. All cases were followed up during first week, third week, first month and third month postoperatively and assessed. Patients assessed by diagnostic nasal endoscopic examination to note any synechiae. If present, their site and patency of the maxillary sinus ostium are noted. age and sex distribution of cases in group A, 11 males and 4 females are included with an average age of 32 years. In group B, 5 females and 10 males are included with an average age of 34 years. Intraoperative findings, cyanonasal polyposis is seen in 80% of cases in group A and 66% in group B. In fungal diseases, 20% in group A and 33% in group B. Results, assessment of postoperative adhesions. Postoperative adhesions are seen in 5 patients in Mitomycin C treated group and 13 cases in control group. Adhesions are absent in 10 cases in Mitomycin treated patients and 2 cases in control group. Assessment of postoperative middle meatal antrostomy patency. Osteum is patent in 14 patients with Mitomycin C treated patients and 3 patients in control group. Osteum is closed in 1 patient in group A and 12 patients in group B. Discussion. At the completion of the cyanonasal surgery, when the injured surfaces are in close proximity, the regenerating epithelium and the fibrous tissue may grow between these surfaces, creating an adhesion. In our study, postoperative adhesions were less in patients treated with Mitomycin C compared to those not treated, whereas Chung et al. In their case control study reported adhesions occurring within 2 months in Mitomycin C treated patients, but the rate of adhesions were less compared on the control side. Our study showed postoperative osteal patency is present in 93.33% in Mitomycin C treated group, whereas Kim et al. In their study showed beneficial effect of Mitomycin C at 3rd month follow-up, but no effect in decreasing the incidence of stenosis and closure of the antrostomy at 6 months and in long-term follow-up. None of this study reported any local or systemic side effect of the MMC application. Conclusion. This study is intended to show that if Mitomycin C can be used safely in human cyanonasal mucosa to prevent adhesion formation and to delay healing of the intranasal antrostomy, we believe that this delay in fibrosis will allow reepithelialization to take place before scar can form, thus increasing the success rate of the functional endoscopic sinus surgery. Our study aims to show that single intraoperative use of Mitomycin C in prevention of synechiae formation and closure of osteomyelitis complex. These are my references, sir. Thank you, sir.
Madam, what is the adequate like metaplastic?
Sir, not audible, sir.
No, what is adequate middle meatal antrostomy? What you want to do? What is adequate? When do you say it is adequate? Because you are only addressing the middle meatal antrostomy, is it?
Yes, sir.
For additions.
Sir?
No, you are addressing only the middle meatus or the entire nasal cavity for additions. Your title says what?
Sir, in my study, I have taken middle meatus, middle meatal antrostomy and addition, sir.
For addition, intranasal additions, what is this one? You have to pack the entire nose. So if you want to pack the entire nose, how will you pack with the Mitomycin C? What is the dilution? How do you pack it?
Sir, I have taken the cotton pledget and rubbed it along the raw surface of the nasal cavity for 5 minutes, sir. And I have left the cotton pledget for 5 minutes, sir.
No. Diluted and it is left for 48
I have diluted 2 milligrams of Mitomycin C. I have diluted with the 2.5 ml of sterile water, sir, to bring it to 0.8 milligrams, sir.
Suppose I want to leave it for 48 hours, what should I do?
So we have to dilute it more, sir.
What? What dilution?
No. See, doctor, you, sir, has correctly pointed out. See, Mitomycin C is a topical applicating drug for a limited contact time.
Sir.
Okay. So you cannot leave it overnight or 48 hours.
Sir.
And in your study, you have not mentioned what is the maximum time for follow-up of your patients.
I have followed up for 3 months, sir.
3 months for a study is not adequate for follow-up. At least 1 year time should be enough. And you have also not made an attempt to answer sir's question.
Sir.
What is an adequate middle meatal antrostomy dimension? you can mention any citation from a book which you have read, like from P.J. Vermont. I'm giving you clues. Any or Dr. Heinz Stamberger, what is the optimum size of middle metal androstomy? See, your topic is a slight deviation from what you are presenting. Your topic heading is something, but you're trying to emphasize on middle metal androstomy. So if it is for an entire nasal cavity, then it is separate implication, but you are talking only on middle metal. So the topic should have been on assessment of outcomes of middle metal androstomy dimensions with and without mitomycin. So you have a comparative case control study.
Yes, sir.
So I'm prepared better next time. Okay.
Yes, sir.
Yeah. Thank you.
Thank you, sir.
Yeah, next presenter can share the screen. Dr. Raj Kumar.
Yes, sir. Am I audible, sir?
Yes, go ahead.
Good evening, sir. My topic is atypical presentations of nasopharyngeal masses. Nasopharyngeal masses have a wide range of presentations attributable to several benign conditions and also a high index of suspicion in need for the timely management. Patients usually present late with history of prolonged treatment, so definitive diagnosis and also early intervention is indicated to prevent the complications. The importance of age in assessing these nasopharyngeal masses cannot be denied because the malignant diseases usually develop later in life, while benign masses are usually identified at a younger age. My aim is to present 4 cases of nasopharyngeal masses with atypical presentations and diagnosis for their age group. Materials and methods include 4 patients aged between 28 and 38 years with nasopharyngeal masses on diagnostic nasal endoscopy who presented to our tertiary care center, of which 3 patients underwent endoscopic excision and 1 patient underwent radiotherapy. Radiological investigations were done for all the 4 patients. So the first case is of a 28-year-old male patient who came to the hospital with chief complaints of recurrent episodes of bleeding from left nasal cavities in 7 months, and it was associated with complaints of left nasal obstruction and mucoid discharge. There was no history of anosmia or hyposmia or any trauma to the nose. There was no history of ear or throat complaints or any comorbidities or any previous ENT surgeries. On diagnostic nasal endoscopy, a pinkish white mass with smooth surface was seen in the left nasal cavity till the middle turbinate and also filling the entire nasopharynx when seen from the right side. So the CT, nose and paranasal sinuses showed a well-defined soft tissue lesion in the posterior cavity, in the left nasal cavity, extending posteriorly into the nasopharynx and into the left spinophallatine foramen, causing the bowing of the posterior wall of the maxillary sinus, which is suggestive of the nasopharyngeal angiofibroma. So this patient underwent endoscopic transnasal excision of the tumor under general anesthesia. This entire mass was excised and delivered via the oral cavity and was sent for histopathological examination. The HP report was suggestive of the tumor, which consisted of proliferation of vessels and also fibroblasts, which was suggestive of nasopharyngeal angiofibroma. So angiofibroma is a benign mesenchymal neoplasm, which is composed of a vascular proliferation within a cellularly dense stroma. Most of these tumors arise from the superior part of the spinophallatine foramen, and they also affect the posterolateral nasal wall of the nasopharynx and also extension into the surrounding tissues. So in this case, the patient is a young male adult in whom angiofibroma is atypical. So in adults, the diagnosis of angiofibroma cannot be excluded. The second case is of a 31-year-old male patient who came to the hospital with complaints of bilateral nasal obstruction for 2 years, which was gradually progressive and not relieved with medications. It was associated with bilateral bloody nasal discharge from 2 years occasionally and also mouth breathing during night. There was history of decreased smell sensation and no history of any ear or throat complaints or any comorbidities or any previous ENT surgeries. On diagnostic nasal endoscopy, a single smooth pinkish vascular mass was seen in the midline of the nasopharynx extending till the choana. It was bleeding profusely on touch. The CT revealed a soft tissue lesion in the anterior convex lesion with anterior convexity, filling the entire nasopharynx and also causing narrowing of the lumen and displacing the soft palate antero-inferiorly. This patient underwent coblation-assisted endoscopic transnasal excision of the mass under general anesthesia, and the mass was sent for histopathological examination. So the HP report was suggestive of a highly vascular tumor with proliferation of the vessels and also round to ovoid cells with hyperchromatic nuclei and also a high mitotic activity, which was suggestive of an angiosarcoma. So the differentials which we considered were the angiofibroma, hemangioma, and venous granulomatosis. The angiosarcomas are malignant neoplasias of rapid growth, which originate from the endothelial cells. Of the overall sarcomas, these represent in the head and neck only 1 to 4% are present, and they're most commonly seen in the middle-aged males. So this clinical presentation overlaps with many other cyanonasal tract lesions. So the angiosarcoma should be considered in the differential diagnosis of a cyanonasal tract mass. So the third case is of a 28-year-old male who came to the hospital with chief complaints of left-sided nasal obstruction for 3 months, which was gradually progressive and not relieved with medications. It was associated with bleeding from left nasal cavity occasionally, which resolved spontaneously. There was history of decreased smell sensation on left side and no history of ear or throat complaints or any comorbidities or previous ENT surgeries. On diagnostic nasal endoscopy, a smooth pinkish lobulated mass was seen in the left nasal cavity, which is attached to the inferior turbinate and extending posteriorly till the nasopharynx, occupying the opposite choana. The end was bleeding on touch. So the CT, nose and paranasal sinuses showed a well-defined soft tissue density mass lesion in the choana, nasopharynx, and also on the left side, and the sphenopalatine foramen. So this patient underwent endoscopic transnasal excision of the mass under general anesthesia with the help of a cobblator, and this mass was excised from its attachment and sent for histopathological examination. The HP report was suggestive of the tissue which consisted of proliferating capillaries and also the giant cells, which was suggestive of a giant cell reparative granuloma. So the differentials which we included, which we were thought was of rhinosporidiosis, angiofibroma. This giant cell reparative granuloma is a rare neoplastic reactive tumor, which was observed most commonly after trauma and inflammation. It occurs most commonly in children and young adults with a high prevalence in young females. So the most common presentation is the mandible and the maxilla, and it is a sporadic tumor in the nasal cavity. So in this case, as there was bowing of the posterior wall of the maxillary sinus, we considered it to be angiofibroma, but the HP report was suggestive of giant cell reparative granuloma. So the fourth case is of a 38-year-old man who came to the hospital with chief complaints of pain behind the left eye, double vision, and numbness over the cheek for 4 weeks. There was no ear complaints or nasal complaints, and there was no history of any swellings in the neck. So in the past history, 1 year ago, the patient was diagnosed with left otitis media with otomastoiditis, for which the patient underwent tympanomastoidectomy, and the patient complaints were partially resolved. On examination, there was left 6 cranial nerve palsy, paresis, and also hypoesthesia of the ophthalmic and maxillary divisions of the trigeminal nerve. So on otoendoscopy, the neotympanum was intact in the left ear, and on diagnostic nasal endoscopy, there was mucopurulent discharge and necrotic debris, which was sent for KOH mount and fungal culture and sensitivity. Along with that, a mucosal bulge was seen in the posterior wall of the nasopharynx near left fossa of Rosenmuller region. So the CT temporal was suggestive of left canal wall of mastoidectomy, post-mastoidectomy status, and MRI was suggestive of the diagnostic possibilities of Rhino-orbital cerebral mucormycosis and also nasopharyngeal malignancies. So biopsy was taken from the mucosal bulge in the nasopharynx and sent for HPE. So KOH mount was tested positive for fungal elements with hyphae, within septate hyphae, and the HPE was suggestive of undifferentiated malignant neoplasm, possibly nasopharyngeal carcinoma. So patient has been treated with intravenous liposomal amphotericin B for 14 days, followed by radiotherapy to treat for the nasopharyngeal carcinoma. So to conclude, the clinical presentation in most of the nasopharyngeal masses will often be the same. So high induction of suspicion and appropriate radiological investigations to assess the morphology, size, and extent of the tumor are required for proper planning and management. The histopathological pattern of nasopharyngeal lesions vary from common benign lesions such as lymphoid tissue to malignant diseases such as lymphoma and nasopharyngeal carcinoma. So though there are specific tumors in a particular age group, all the other diagnoses should also be considered, including the malignancies. So these are my references, sir. Thank you.
You have presented your series, but what other atypical nasopharyngeal masses have been reported?
Sir, these 4 were the cases reported to our center, sir.
Yes, I know that.
Yes,
but we
sir.
should be aware of other possibilities. So I'm asking, you should have prepared. So I'm asking, what are the other atypical nasopharyngeal masses which can present, reported in literature?
Yes, sir. They can be like fibromas, chordomas.
No, that is.
Yes.
Okay. Sir, you'll ask.
Yes. Fine. The presentation was short and crisp, but try to stick to some time. And
yes.
Can you explain? Did any of your patients present with any neck mass?
Sir, no, sir. No neck masses, sir. Nobody presented with a
You
neck.
mentioned one patient had a post-radiotherapy treatment. He had come.
Sir.
Out of 4 cases, 3 had undergone surgery. One had
One we
undergone
sent
treatment.
for radiotherapy.
Radiotherapy. What was the reason to send the patient for radiotherapy? It was nasopharyngeal carcinoma.
Yes, sir. The HP report came as nasopharyngeal carcinoma, so we sent him for the radiotherapy, sir.
Okay. Why radiation therapy is preferred over surgery?
Sir,
in cases of nasopharyngeal carcinoma.
Sir, because the extent of the tumor cannot be resected with with negative margins, sir. So the stage, depending on the stage, we send for a patient for the radiotherapy, sir.
The tumor literally melts on radiation therapy. But how did you follow up these patients?
Sir, the 3 patients who underwent excision, we followed up the patient with diagnostic nasal endoscopy, sir, post-operatively, and there was no recurrence of the lesion, and also patients were symptomatically better, sir. No any complaints, and
okay, thank you.
Yes, thank you, sir.
Next presenter, Dr. Shravan.
Yes, sir.
Please share your screen.
Good evening, sir. Am I audible and video?
Yeah, go ahead.
Thank you, sir. So myself, Dr. G. Shravan Kumar. So the presentation for today's case series is the magnetic resonance imaging MRI features of Rhino-orbital mucormycosis. So before proceeding, we'll introduce about mucor. Mucormycosis is an acute fulminant and often opportunistic infection. It typically affects diabetic or immunocompromised patients. So if we see, mucor belongs to the family Mucoraceae along with other members, that is Rhizopus, Rhizomucor, Apsidia and Apophysomyces. They belong to Mucorales order and class Zygomystis and phylum Zygomycota and the kingdom fungi. So most commonly mucormycosis affects the nose and paranasal sinuses. So after infection of this nasal cavity and paranasal sinuses, the fungi can cause a necrotizing vasculitis that extends deeply into this deep face, orbits, cranial cavity and brain. So here we retrospectively reviewed the MRI findings in a series of 40 patients with the rhino-orbital mucormycosis, so that we can establish a common radiographic pattern that can be helpful in predicting the diagnosis of this infection. So 40 patients were studied. The aim, what is the aim of the study is to study the MRI features of rhino-orbital mucormycosis. Materials and methods. The type of study is the retrospective study of sample size 40, of duration of the study is 6 months, that is from March 2021 to August 2021. And the investigations we have done is MRI, PNS and orbits with 1.5 Tesla, and the MRI included T1 weighted, T2 weighted and post contrast T1 with all the 3 cuts, coronal, axial and sagittal cuts. So if we see the inclusion criteria, So all the patients who are presented to the ENT department with histologically proven Rhino-orbital mucormycosis were included in this study, and with the cerebral involvement, and in the cases where contrast cannot be used, are excluded from our study. So if we see the results of the study, most of the patients were male, 65%, and remaining 35% are female. And if we see diabetics versus non-diabetic, the diabetics are almost 28 among 40 patients. That includes almost 70%, and the remaining 30% are non-diabetic. If we see age distribution, majority of the patients were in the age group of 41 to 50, followed by 51 to 60. Among them, almost the COVID survivors, almost 77.5% are the COVID affected and mucormycosis positive, and the remaining are the non-COVID persons. So if we see the presenting complaints of the patient, so most of the patients presented with fever, almost 30 patients among 40, 30 presented with the fever, and remaining 28 presented with headache, and some presented with the nasal discharge, facial swelling, facial pain, and decreased vision. So this is the variable presentation of the patients. And if we see radiological involvement of the disease, so almost 40 out of 40 patients, maxillary sinus and ethmoidal sinus were involved, and followed by the frontal sinus and then the sphenoid sinus. And the extra sinus involvement included premaxilla, pterygopalatine, infratemporal fossa, orbit, and bony erosion. So if we see the MRI features, so we have done three. One is T1 weighted image, T2 weighted image. Second is the contrast study, that is enhancement pattern. So in T1 weighted signal, so almost 35 cases among 40 cases, they showed hypointensity. In T2 weighted signal, almost 16 patients showed hypo to isointensity, and 13 patients showed heterogeneous intensity, and 11 patients showed hyperintensity. And in the contrast study, enhancement pattern, almost intense homogeneity is observed in 10 patients. Heterogeneity is observed in 17 patients, and some patients, 13 patients presented with central non-enhancement with ring enhancement. So here if we see in T2 weighted signal, almost 13 patients were heterogeneous, and in post-contrast study also 17 patients were heterogeneous, which is making our diagnosis somewhat difficult. So if we see the pattern, so here the T2 images that is showing maxillary sinus heterogeneous pattern. First picture is it is showing the maxillary sinus heterogeneous pattern. Below it there is an isointense pattern involving the maxillary sinus, and here if we see T2 hyperintense pattern involving the sphenoid. In post contrast study, the different type of pictures, hypointense, intense enhancement pattern, and in intense enhancement pattern, the left premaxillary region is also observed. So these are the other variable presentations that are involving just they are showing the mucosal thickening of this maxillary sinus and other sinuses. So coming to the discussion, so our study included almost 40 patients of proven mucormycosis, and all the patients underwent MRI imaging T1, T2, and post contrast, and all the findings were documented. So here the patients initially presented with cyanonasal involvement, but it later spread to the orbits, face, pterygopalatine fossa, hard palate, maxillary alveolus, and zygomatic process. So among all patterns of MRI, here if we observe in the discussion, so T1 hypointensity and T2 hypointensity, these are the two major appearances were seen in most of the cases, and remaining majority showed heterogeneous pattern. So here the T1 hypointensity and T2 hypointensity, it is considered in more studies, it may be due to the presence of iron and manganese in the fungal elements, which decreased the contrast uptake. And so here what happened is the T2 weighted images as well as contrast findings, they are variable and are not reliable markers. So and imaging like MRI, it shows variable, and sometimes it has shown mucosal thickening in early stages of the disease, which delayed the diagnosis of mucormycosis. So finally, I want to conclude this study. So in this study, the imaging showed different patterns of enhancement and signal intensities with extra sinus involvement. So imaging alone cannot be useful in diagnosing fungal disease. It definitely requires a clinical as well as pathological correlation. But what is the use of MRI then in patients of mucormycosis? So it is found out that the MRI can be useful to know the extra sinus involvement, to know the extent of disease and any complications like cavernous sinus thrombosis or internal carotid artery thrombosis. So the complications can be picked up, and it will definitely serve as a route map for the surgeon to proceed for the surgery. So in final conclusion, I want to conclude that MRI imaging alone cannot be useful in diagnosing, but it can aid in the in knowing the extrasinus involvement, extent complications, and it serves as a roadmap for the surgery. These are my references.
What
Yes,
is
thank you.
MPR?
Sir?
What is
No,
the expansion of MPR? What is multiplanar MRI?
A different lane, sir. That shows that includes
Yeah. Hello.
Sir.
Okay. Did you answer sir's question?
No, sir. I'm not getting
Okay.
statements. Sir.
Okay, sir.
Okay. So it is a very good presentation to emphasize on the importance of MRI. What is the role of MRI in follow-up? Do you do MRI in follow-up patients?
Yes, sir. We can know any residual disease, and it could be residual or could be recurrence also. So we can know this thing.
When do you say there is a residue, and when do you say that there is a recurrence?
Recurrence. If there is a gap of like if patients are presenting immediately post-op with the same like within 6 weeks interval, then it is residual, sir. If after 6 weeks, then we can call it as a recurrence, sir, with again similar presentation.
So according to you, after 6 weeks, we should do repeat MRI.
Means if we suspect any clinical features, we can proceed, sir.
Any other important message you would like to give apart from the routine importance of MRI? Any other new take-home points? Because whatever you have presented is something which is already known. Thanks to COVID time, everyone were utilizing the facilities of MRI and getting valuable information regarding surgical planning and things. Any other new sign or any other new valuable points which helped you in diagnosing that it is most likely mucormycosis and not any other space occupying lesion or not other sinusitis, things like that?
Yes, sir. Previously, this black turbinate sign was considered to be specific for this mucormycosis, sir. But now, recently,
That
it
is
is not.
That is endoscopic. We are talking only purely MRI.
Yeah,
So
yes.
in MRI, any other new point you want to share? If it is there, you tell.
Yes, sir. The same old points, sir. Hypointensity will mostly favor the diagnosis of mucormycosis, sir. Hypo to isointensity. If it is hyperintensity, then we can think some others. And when there is a central non-enhancement with rim enhancement, then definitely we should suspect a mucosa.
Fine. Thank you.
Yes, thank you so much.
Next presenter, do share your screen.
Yes, sir.
Dr. Lakshmi.
Yes. Good evening,
Dinesh,
sir.
Yeah.
My case series is on correlation between the grade of microtia and hearing levels in patients with congenital microtia. Introduction. Congenital microtia occurs due to aberrant development of first and second laryngeal arches. The incidence has been reported to be 1 in 10,000 population, and mostly it is a unilateral anomaly with right-sided dominance. Microtia is known to be associated along with congenital oral atresia, and both of these are associated with conductive or mixed hearing loss.
Aim of my study is to evaluate the relation between the audiological and clinical findings in patients with congenital microtia. Method, this is a cross-sectional study. I have selected 10 patients who were presented to our OPD with abnormal ear shape, and they were subjected to full history taking, otological and audiological evaluation. Otological examination was done to grade the microtia according to Mark's classification. And then audiological evaluation was done by pure tone audiometry, and they were graded according to WHO classification. For statistical analysis, I have used Spearman role calculator. Coming to the age and sex distribution, for a population with less than 10 years, male and female distribution were equal, whereas beyond 10 years, female predominance was noted. Laterality of microtia. In my current study, all the cases were unilateral with both right and left side with equal distribution. And distribution of conditions associated with microtia. There are 60% of the cases had congenital canal atresia, and 20% of the cases had congenital facial palsy, and another 20% had Down syndrome. Mark's classification, grade 1. Grade 1 is classified as smaller pinna, but all the features of a normal pinna will be recognizable. In grade 2, some features of a normal pinna will be recognizable. Grade 3 is rudiment of soft tissue and cartilages, almost looking like a peanut. In grade 4, it is absent pinna or ear canal, also known as anoxia. So these are the grading of microtia according to Mark's classification. First two pictures were grade 2 microtia, which were associated with congenital canal atresia also. Grade 3 is rudiment or soft tissue seen. In grade 4 is anoxia. The number of subjects which are according to the grade of microtia, 30% of the cases had grade 1, and another 30% had grade 2 microtia, and another 30% had grade 3 microtia. Remaining 10% had grade 4 microtia. And the hearing impairment was graded according to the WHO's classification. Grade 1 being the hearing level which is better than or equal to 25 decibels. Grade 1 is 26 to 40 decibel. Grade 2 is 41 to 60 decibel. Grade 3 is 61 to 80 decibel. And grade 4 which is greater than or equal to 81 decibels. The distribution of subjects according to the grading, 30% of the patients suffered from grade 1 hearing loss, and 40% had grade 2 hearing loss, and 20% of the cases had grade 3 hearing loss, and remaining 10% had grade 4 hearing loss. The analysis was conducted between the grade of microtia and hearing level using Spearman's rank correlation test, and there were two sets of data. Data set A being the grade of microtia, and data set B signifies the severity of the hearing level in decibels. And there were around 10 pairs of data in each set, and the rank value was calculated to be 0.7, which falls in the range of strong positive correlation. So this correlation does not imply causation because one variable may not cause the other, but it is statistically significant. And this is a scatter graph showing the grade of microtia and severity of hearing level. The trend line is, you can see the trend line which shows the strength of the correlation. The results obtained, the age of the patients varied between 7 to 14 years in my study, and majority fell in first decade. And in present study, the male and female were equally affected, which is actually inconsistent with the usual male predominance in the previous studies. In laterality of microtia, I observed a right-sided predominance, that is 60%, which matched with the previous results. And there appears to be strong positive correlation between the severity and the grade of microtia, according to the R value. Conclusion, the better developed the external ear, better will be the hearing level. So despite the importance which is given to the clinical grading and the audiological evaluation, equal importance has to be given even to the radiological investigation like HRCT temporal bone, because most of the cases will have associated temporal bone anomalies also. And the management is of even though it is most of the cases will have a unilateral hearing loss, the unilateral hearing loss has to be treated because binaural hearing is important for the normal development of the speech and language. And when managing a child with microtia, equal consideration has to be given to both cosmetic as well as hearing rehabilitation. And here are my references. Thank you.
Along with your hearing rehabilitation, what else is required? I mean,
the multidisciplinary approach has to be done, sir. For reconstruction has to be done.
Okay. Then what else? You should include psychological counseling. Very important.
Yes.
What are the syndromes associated with the microtia?
Treacher-Collins syndrome, golden heart syndrome, Down syndrome, and brachio-otorenal syndrome.
Okay, doctor, can you, if you don't mind, go to the slide before results?
Yes.
Yeah, can you explain this slide? What chart it is?
This is called a scatter graph, sir. I have pointed the x-axis shows the grade of microtia and y-axis being the severity. I have plotted all the data, and the graph obtained is, you can see the line. This is called the trend line, which is in the dotted red line is called trend line. This shows the visual field of strength of our correlation.
Okay, if the lines are more towards the right, what is the significance?
It is a positive correlation, sir, and it is upsloping also.
Okay, so what is the ideal time you want to operate a child who has grade 4 microtia? Grade 4 kind of a in a
Yes, like
what would be the age when you would like to operate?
I'll wait up to 8 to 10 years of age, sir, to allow for the adequate costal cartilage, because we have to harvest the costal cartilage for reconstruction. So minimum
Usually 6
years.
years is the ideal time you can wait.
Okay.
Okay. What are the other substitutes apart from costochondral junction cartilage? What are the other substitutes you can take?
Polyethylene can be taken. The artificial implants can be done. Prosthesis can be done.
Any role of implants with bridges?
It's a
like
bone anchored hearing aid and middle ear implants can be used for if we ruled out other anomalies.
Did your patient have any other coexisting anomalies?
Yes, like 60% of the cases had a congenital canal atresia also. So,
Okay. Thank you.
yes. Thank you, sir.
Next presenter, Dr. Fazlur Rahman.
Yes.
Next presenter, Dr. Fazlur Rahman. Please share your screen. Are you there? Dr. Rahman, you are there. Please respond. The next presenter, Dr. G. Ramya. Next presenter, Dr. G. Ramya. If you are around, please share your screen. Dr. G. Ramya. Can you hear my voice?
I think the candidate is there. G. Ramya is logged in,
Yeah,
but
is
they
there.
are not. I would request all the residents to type in the chat box whoever are present henceforth, because we are waiting for the candidates to present. If you are ready,
Yeah.
just mention ready in the chat box.
Dr. G. Ramya, are you there? If you are not there, we are going for the next one. Dr. Sheikh Shafiun.
Am I audible, sir?
Yeah, you are audible.
Okay.
Please share your screen.
Okay.
Dinesh sir, her number is 26. Dr. Sheikh Shafiun from
Okay.
Pratima.
Yes, I think we have 24, 25 have not responded. We are supposed to score for 26.
Yeah.
My screen is visible, sir.
No.
Doctor, press F5 function key. Very good. Okay.
Okay, sir.
Okay, go ahead.
Perfect. Good evening, sir. Good evening, everyone. I'm Dr. Shafiam, presenting clinico-pathological characteristics of various cyanonasal masses in tertiary care center. So, introduction. The cyanonasal masses is a common clinical entity. It has a varied etiology ranging from non-neoplastic to neoplastic lesions. The presenting features and symptomatology of all cyanonasal masses are similar. That is, a nasal obstruction, rhinorrhea, epistaxis, orbital symptoms, etc. A detailed history, clinical examination, proper imaging, and most importantly, thorough histopathological evaluation are essential part of workup of patient so that a required and timely intervention is done. My aim is to study the clinico-pathological characteristics of various cyanonasal masses, and objectives are to study the clinical profile of cyanonasal masses in terms of demographic profile, clinical presentation, and clinico-pathological diagnosis. Materials and methods. The study was conducted among 30 subjects for a period of 7 months from Jan 2023 to July 23. Consent was taken, thorough history and clinical examination was done, and diagnostic nasal endoscopy plus biopsy followed by histopathological examination was performed for all these cases. CT-PNS and MRA-PNS was performed for some extensive cases. Based on the clinical science and investigations, a diagnosis was arrived and appropriate medical or surgical management or both were carried out. The patients were followed up for a period of 3 to 6 months. All the subjects with the nasal masses on anterior rhinoscopy and diagnostic endoscopy, and all the subjects between the age group of 10 to 60 years were included in our study group, and all the subjects with adenoid hypertrophy in diagnostic nasal endoscopy are excluded. Here we present some of the few cases from our study group. A 45-year-old female came with complaints of left-sided nasal obstruction and a nasal discharge since 2 months and left-sided periorbital swelling from since 15 days, with a history of weight loss and with no addictions. Diagnostic nasal endoscopy showed a mass which is seen in the left nasal cavity, which seemed to be arising from the lateral wall of the nose, pushing the middle turbinate medially. And contrast enhanced CT-PNS was done, showing a soft tissue opacity, density involving the left nasal cavity, extending the bilateral ethmoidal sinuses, and the mass also involving the medial wall of the orbit and pushing the septum towards right side, and also the contrast and the mass causing this mass is also causing deviation of the nasal septum towards the right side. It was showing the diffuse heterogeneous enhancement on post contrast, and biopsy was sent, and biopsy was sent and it was confirmed as squamous cell carcinoma. After that, endoscopic debridement of the nasal mass was done. And the second case, here I am presenting a 10-year-old boy with facial asymmetry, and his clinical features showed, and he is having complaint of left-sided nasal obstruction since 1 year, which was progressive type in nature, and he was not having any snoring episodes during night time. He was not complaining of about snoring. And here we can see on examination there is a facial asymmetry with a frontal bossing of the frontal bossing and saddle nose deformity was seen, and overcrowding of teeth was seen. And on diagnostic nasal endoscopy, there was a polypoidal mass seen over the there was a polypoidal mass seen occluding the left nasal cavity. Then contrast enhanced CT-PNS was done with showing the left nasal a soft tissue opacity involving the left nasal cavity, and there is a hyperaeration of the hypernematization of the frontal as well as the ethmoidal air cells, as well as a fibrous dysplasia of the frontoparietal bone was seen. This feature suggestive of the Dyke-Davidoff-Masson syndrome, and endoscopic excision of the nasal mass was done. After that, it was sent for histopathological examination, and it was confirmed as an inflammatory nasal polyp. And the last case is a 29 years old male complaining of left-sided nasal obstruction with nasal bleed since 3 months. With addictions and with history of weight loss. Addictions like he was having a tobacco chewing, history smoking, and consuming alcohol, and diagnostic nasal endoscopy showing the pinkish polypoidal pinkish mass, which was solitary mass protruding from the left nasal cavity, which was sensitive to probing, and bleeds on touch arising from the roof of the left nasal cavity. Then contrast enhanced CT PNS was done. There was a soft tissue mass density, and the lesion which was superiorly extending up to the cribriform plate, and posteriorly it was extending up to the choana. There was occlusion and widening of the maxillary infundibulum, and left frontonasal nasal recess was noted. And on histopathological examination was done, and and it was confirmed as primitive neuroectodermal tumor. Patient was managed by surgical resection of the tumor, followed by radiotherapy and chemotherapy. So, presenting symptoms of the cyanonasal masses in my study subject, most of the patients presented with a nasal obstruction of which accounts to about 73.3%, and with the most common age group is between 41 to 50 years age group, which accounts to about 26.6%, and in this among the cyanonasal masses, the non-neoplastic lesions, the two inflammatory nasal polyps accounts for about 63%, and neoplastic accounts to about very less 16%. Then distribution of study according to socio-demographic variables and types of the disease. So males, among the males and females, so males were predominant when compared to females, of a ratio of about 1.5:1, and those people who are residing, those subjects who are residing in the rural areas accounts to about 70% when compared to about urban areas, and the socio-economic status of about lower socio-economic status were contributes to about 36.6% when compared to upper middle, lower middle, and upper lower class subjects. And discussion. The cyanonasal tract and the paranasal sinuses are, although having they bore a complex variety of lesions ranging from non-neoplastic to neoplastic. Different kinds of elements such as epithelial, glandular, bony, cartilage are there in nasal cavity and paranasal sinuses. Along with this, the tract is exposed to various infective agents, chemicals, antigens, and mechanical factors. All these factors make a cyanonasal tract prone to give rise to a very differential diagnosis of the masses. Detailed history, clinicopathological evaluation makes to reach the provisional diagnosis. For confirmation of the disease, histopathological evaluation is the gold standard that guides in management and to know the prognosis. Conclusion, cyanonasal masses presented with trivials of symptoms like nasal obstruction or nasal discharge, but with wide spectrum of differential diagnosis. The inflammatory lesions outnumbered the neoplastic lesions in our study, out of which polyps are the most common benign lesions. Histopathological study remains the mainstay in the final diagnosis. These are my references, sir. Thank you, sir.
Okay, you have managed a very interesting case. I would like to congratulate your team for addressing some rare cases.
Thank you, sir.
So that patient, that boy who had such a facial dysmorphic condition
Yes, sir.
and
Yes, sir.
syndromic condition, it was must be challenging to operate. Though
Yes, sir.
that lesion is seen to arise from which part of the nasal cavity?
Sir, lateral wall of the nasal cavity, it is seem to be arising, sir. Most probably the maxillary sinus, sir.
So that is okay. Lateral wall of the nose, not necessarily maxillary cavity, because the maxillary sinus was normal on the left side. It was arising from the lateral wall of the nose. So what was your follow-up for this kid?
Follow-up.
Duration?
Sir, duration of follow-up, sir. Patient was operated in June, sir. So after 4 weeks, we followed up this patient, sir, for 3 months, sir. Then he's not having any recurrences or again obstructions, sir, of any complaints.
You need some more time for follow-up. But one good important message you have put forward in this portal is any suspicious mass, before you take up the patient for any endoscopic sinus surgical procedure, always go get a working diagnosis by doing a biopsy.
Yes, sir.
And in case there is any suspicion, you can subject it for immunohistochemistry markers. I would like to hear if there is any immunohistochemistry markers and which will help you in diagnosis and prognosticating. So that can add good value to your study. Okay, you can do better. Okay.
Thank you, sir.
Yeah.
Okay.
Yeah.
Sir,
Well,
Anil sir, any questions?
Anil sir.
Next.
Okay, fine. Thank you. Thank you.
Okay. Next presenter, Dr. G. Lalita.
Sir,
Yeah, you're there.
this is G. Ramya, sir.
Next is
25, sir.
yeah, you can present at the end.
Okay,
We
sir.
called you, you didn't respond that time.
Okay,
Dr.
sir.
Lalita, you are ready?
Yes, sir.
Please share your screen.
Good evening, all. I'm Dalita. Today I'm presenting case series of nasal endoscopy in diagnosis and management of cyanogenic headache. Headache is a frequent and common painful state which affects the human in the most form of pain in the trigeminal territory and contribution of nasopharyngeal vagus and first three of cervical nerves. Modern endoscopy sinus surgery is divided into
Dr.
mesothelial and
Lalita, just a minute. Sorry to interrupt you. Press F5 function key. It will become full screen.
okay, sir.
Yes, good. Proceed.
Modern endoscopic sinus surgery is divided into mesenchymal and vagal approaches. The mesenchymal approach is ideal for patients with anterior rhythmoids. It's a form of it's from anterior to posterior. The vagal approach is, in contrast, ideal for the patients with sinusitis who may not respond to limited surgery. This approach is from posterior to anterior. Anatomy and physiology. The paranasal sinuses are air-filled extensions of the nasal cavity. There are four air sinuses named accordingly where they are situated in the bone. Accordingly, maxillary, frontal, sphenoid, and ethmoid. Each sinus is lined by ciliated pseudostratified epithelium and filled with the mucus-secreting globate cells. The function of the paranasal sinus is lightening the head and supporting the immune defense of the nasal cavity, humidifying the inspired air, and increasing the resonance of the voice. Aims and objectives of my study: to evaluate the usefulness of the nasal endoscopy in diagnosis and management of the cyanogenic headache. Inclusion and exclusion criteria. Inclusion criteria is patients presenting with a cyanogenic headache of all age groups and sex. Exclusion criteria is the patients already treated on treatment with cyanogenic headache and patients with headache like traumatic headache, hypertensive headache, exhaustion headache like that. Non-cyanogenic headache are excluded. Materials and methods. The data is collected on the basis of the detailed history, systemic examination, and ENT examination and investigation. 50 patients were included in my study, and they are divided into two different groups based on age, sex, and severity. Patients with at least two major and one minor criteria of symptoms, like major criteria includes fullness of head and nasal obstruction, post-nasal drip are major criteria. Cough, ear pain, and dental pain are minor criteria. Two major and one minor criteria is divided as severity. One major and two minor are moderate. All minor is mild symptoms. All their symptoms are graded preoperatively and mild, moderate, and severe based on criteria. Here in chart, most of the age group affected is 15 to 25 years age group is more affected, and male and female are equally affected. Females are just higher affected. So severity complaints wise, moderate severe people are more high. Investigations to confirm the diagnosis, X-ray PNS was done in all patients. CT PNS was done with the only severe symptoms of the patient. It's 27% patients we can do in CT PNS. All among 50 patients we can do X-ray PNS. Diagnosis in our study group, 84% of the diagnosed as chronic rhinosinusitis with DNS, 6% is only DNS, and 6% is only chronic rhinosinusitis. Four number of patients has no abnormal nasal complaints. So CRS, chronic rhinosinusitis, out of 50, it's 100, it's 6%, DNS is 6%, CRS plus DNS is 84%. No abnormality of the nasal cavity is 4%. Treatment in our study of 50 patients, all the patients underwent medical treatment. Out of these, 48 patients underwent both medical and surgical modalities of treatment. Outcome medical treatment, only 2 patients got relieved with completely relieved with the medical treatment. 48 patients with medical and surgical treatment got relieved completely. Symptoms after treatment. In our study of 50 patients who has taken treatment, 11 patients has mild nasal symptoms, that is 22% of nasal obstruction was due to crust formation relieved after saline nasal drops. 6 patients had non-nasal complaints, like 12% complained with dry crusting, symptomatic treatment during the follow-up. 33 patients with moderate and severe symptoms who underwent endoscopic sinus surgery coped well and symptoms relieved as noted in regular follow-up. Complete resolution of the symptoms were seen in these patients in 3 to 6 months. Discussion. Sinogenic headache is more common in younger age group females. It is commonly associated with a nasal obstruction, postnasal drip, ear pain, dental pain, and cough. Nasal obstruction with headache is the commonest symptom from all the symptoms. Facial pain, majority of the patients believed that surgery was beneficial. FESS is an effective procedure to relieve the symptoms of CRS with nasal obstruction and postnasal drip. Improvement in quality of life was achieved in 85% of the people after post-operative period of 3 to 6 months. Review literature. These are the review literature. I referred several early reports of endoscopic diagnostic and therapeutic procedures in the nose and maxillary sinuses were published in the German literature. 1925, Melch, a New York rhinologist, it's a journal, and 1978, Mason Klinger, it's a journal. These are my references. Thank you.
Okay. So, who coined the term FESS? Okay. Dr. David Kennedy. So Dr. David Kennedy coined the term FESS, functional endoscopic sinus surgery. Regarding your factors, major and minor criteria, how many of your patients came in major criteria and minor criteria? How was the presenting symptom? All had appropriate major criteria?
Some of them are only minor criteria. Those are called mild symptoms, like ear pain, dental pain, cough. Moderate symptoms are more, sir. Comparatively severe, mild, moderate symptoms are more. That includes 1 major, 2 minor criteria.
Okay.
Can you explain this mucosal contact point?
Then in sinusitis, mucosal thickening will be increased, sir.
What is the theory?
It's ciliary function will be decreased.
Theory, madam.
Theory, don't understand.
Mucosal point, contact point, headaches. Okay, okay.
Next presenter. Dr. J. Ramya Deepika.
Yes, sir.
Yeah, please share your screen.
Yes, sir.
The other candidates who didn't present earlier, Dr.
Sir,
Nikita.
one more is this.
Yeah, sir. That actually that is a case report, sir. We have shifted them to tomorrow.
Okay.
And one request, in most of your presentation, you have kept the patient's photo without fading it. Unless and until patient has given consent, please don't share photos without fading the eyes. Maintain patient's identity and privacy. You can proceed.
Yes, sir. Good evening, everyone. I'm here to present a case series on a study on foreign body in air and food passages. So coming to the introduction, the foreign bodies in air and food passages constitute as an emergency problem. As a child who was perfectly all right suddenly gets restless and dyspneic, the foreign body should be removed as an emergency and all the procedures should be available. Even though it is done by a little bit of delay, it should be a well-planned procedure. The diagnosis is made by proper history and clinical examination. Uh, Prognosis is generally good if the patient is brought early and the treatment is done immediately, and any delay in proper diagnosis and treatment will cause morbidity and mortality. The foreign bodies in air and air passages show variation in shape, size, nature, and the clinical picture which they produce. A study on common occurrences of foreign body in air and food passages of 100 cases have been undertaken, and the statistical evaluation in regards to the incidence of foreign body of different age groups, sex, and seasonal variations were done. Clinical and radiological and therapeutic evaluation of cases of foreign body in food and air passages has been undertaken. The aim of the study is to see the different types of foreign bodies in different age groups and their location. Methods and materials. It is a retrospective study of foreign bodies in food and air passages. It was conducted on 100 patients who attended the ENT department. The foreign bodies in the larynx, trachea, bronchi, hypopharynx, and esophagus were undertaken. Exclusion criteria are the foreign bodies which were present in the nasal cavities, nasopharynx, and the oropharynx. The diagnosis was done in detail by taking a detailed clinical history. Thorough examination of ear, nose, throat, head, and neck was done. Based on history, clinical examination, and radiological findings, cases were selected for further evaluation and study. Complete blood examination, chest X-ray, PA view and lateral view were done, and soft tissues of neck, AP, and lateral view were done. Bronchoscopy was done under general anesthesia for foreign bodies of the airway. Here we can see the demographics of of foreign bodies in food passage. The youngest age group which we saw was 6 months, and the oldest were among about 80 years. It is more common. The incidence is more common in the age group of 0 to 5. Here we can see an aluminum foil present in the esophagus. Demographic distribution of foreign body in food passages. In the younger age group, most commonly the foreign body which we encountered were coins, metal rings, and safety pins. And in the elder age group, the most commonest was the fish bone, followed by mutton and chicken bones and dentures in the eldest age group. The sex demographic distribution of foreign body in food passages it was almost equal in both the sexes. Diagnosis was made under X-ray, esophagoscopy under general anesthesia, and the foreign body was removed. Post-operatively, antibiotics were given for 5 days. The symptoms of foreign bodies in food passages were most commonly dysphagia, followed by throat pain, followed by odynophagia and vomitings. The most commonest symptoms told by the patients were throat pain, discomfort in the throat, and pricking sensation. Few patients had also fever associated with it. The demographic distribution of foreign bodies in air passages are
The age group commonest which we encountered were 3 years, youngest was 3 years, and the oldest was 60 years. It is most common among 1 to 5 years of age group, and it is almost equal in both the sexes. Here we can see a piece of pen cap lodged into the right bronchus. The nature of the foreign body in air passages, most common are groundnuts and custard seeds. Here we can see a wooden bead which was embedded in the air passage. Coming to the symptoms of the foreign bodies in air passages, most of the patients complained of breathlessness of sudden onset, and a few patients complained of cough and associated fever. The study of 36 cases showed that 20 cases of foreign bodies in the right bronchus and 7 cases of foreign body in the left bronchus, 9 cases of foreign body in the trachea. The most common foreign body encounterment is seen in the right bronchus because of its vertical nature and larger diameter. Conclusion, the foreign bodies in the air passages are more common in young childhood. Young children up to 5 years of age. No age was exempted in the cases of foreign bodies in food passages. Mortality is almost nil if diagnosed and treated properly in time. Prognosis is good if the patient was brought immediately. General anesthesia is safe and preferred. Complications increase as the duration increases. These are my few other references. Thank you.
How will you remove an open safety pin?
Sir, we did esophagoscopy, sir. There are actually 21 other procedures, but we preferred esophagoscopy.
What instrument did you use?
Sorry, sir?
What instrument did you use to remove an open safety?
Sir, Chevalier-Jackson esophagoscope, sir.
No, madam. To remove the forceps.
Forceps, right-angled forceps, sir.
Any country which has, how do you prevent this foreign bodies? Aerogel, gas tube, tract.
Prevention. Sorry, sir.
No, you should give education to children, schools.
Yes, sir. Usually the parents should be aware when the kids are playing with any objects to prevent the ingestion of them.
Which country has a program for this? Any idea?
No, sir.
Okay, thank you.
Right, thank you.
Thank you, sir.
Yeah. Next presenter. Yeah.
The presenters.
Dr. Nikita is there from Chelmad.
Sir, yes, sir, I'm there.
Yeah, please share your screen.
What about number 24, 25?
25 is there, sir. After this, after Nikita,
Okay.
she will present. Yeah.
24 is absent, huh?
Yeah, he didn't respond.
Okay.
Dr.
Is
Faizur
there?
Rahman, if you are available, please be prepared with the presentation.
Now we are going to 16, huh?
Yes, sir. 16.
Sir, is my screen visible, sir?
Yeah.
Good evening, sir.
Go ahead.
Myself, Dr. Nikita. My topic is evaluating the effectiveness of two different endoscopic procedures in treatment of antrochoanal polyp.
Okay, proceed.
To begin with, antrochoanal polyps are benign polypoidal lesions that originate from the mucosa of the maxillary sinus, extending into the nasal cavity through the natural sinus ostium or through its accessory ostium. The endoscopic technique has become the most widely accepted approach, with Cadver-Lux procedure being performed in recurrent cases. It is not always possible to locate and reach the maxillary stalk of the antrochoanal polyp purely endoscopically, especially when it is on the anterior or inferior wall of the maxillary sinus. For this reason, different surgical approaches have been proposed in association with endoscopic techniques in order to avoid recurrence due to incomplete removal of the polyp by providing less morbidity and low rate of complications. Better visualization and access to the maxillary sinus can be obtained by combining endoscopic sinus surgery with mini cadolup procedure, canine fossa puncture, inferior meatal antrostomy, and prelacrimal recess approach. My goal of study is to compare the rate of recurrence of two different endoscopic approaches for the treatment of antrochoanal polyp. The first technique was endoscopic antrochoanal polypectomy with middle meatal antrostomy, and the second was endoscopic antrochoanal polypectomy combined with both middle meatal antrostomy and a minimal access through inferior meatus. Materials and methods. It is a prospective comparative study carried out in ENT outpatient department for a study period of 18 months with a sample size of 42 patients. Inclusion criteria: all the patients who are diagnosed by clinical examination, nasal endoscopy and radiological examination with CT paranasal sinuses, patients aged above 10 years and below 50 years, unilateral antrochoanal polyps with no obvious bone destruction, revision cases or recurrent cases were included. Exclusion criteria: involvement of another nasal sinus on CT, patients aged below 10 years and above 50 years, patients with uncontrolled systemic disease or coagulopathy have been excluded. Methodology: in my study, I divided two groups equally, Group A and Group B. In Group A, we performed endoscopic polypectomy with middle meatal antrostomy, which was a standard approach. And in Group B, we performed endoscopic polypectomy with middle meatal antrostomy plus minimal access through inferior meatus. Post-operatively, all the patients were followed up in outpatient setting with nasal endoscopy after 1 week, 3 weeks, 1 month, 3 months and 6 months, and then after every 1 year. The noted outcomes were: out of 42 patients, 26 were males and 16 were females. Age group ranged from 10 to 50 years with a mean age group of 27 years. 14 patients were 16 years or younger. Out of 42 cases, 26 cases were right-sided and 16 cases were left-sided. Out of 42 cases, 8 recurrent cases were referred to us from the other centers. Out of 42 patients, 21 patients were operated on using a standard approach in which 4 had recurrence, and another 21 underwent combined approach in which only 1 had recurrence. This is a comparison table in which recurrent rate was being shown in standard and combined approach. Patients operated on standard approach, 21 patients were operated, of which only 4 had recurrence, and those operated with combined approach, only 1 had recurrence. So the recurrence rate was reduced from 19% to 4.7%. The difference between two groups was statistically significant, p-value being 0.04. The earliest case of the recurrence was identified post-operatively at 8 months. At endoscopic follow-up, recurrence was identified as polypoidal mass originating from the maxillary sinus, which was not responding to medical therapy. No major complications were reported after surgery or at follow-up. 2 patients operated with combined approach had an anterior synechiae between the nasal septum and inferior turbinate. None of the patients in either group presented with epiphora post-operatively. This is a small video clip showing right-sided antrochoanal polyp in which we performed inferior meatal antrostomy after medializing inferior turbinate, through which we can see the nasal polyp in the maxillary antrum. To talk on antrochoanal polyp, an antrochoanal polyp is a benign sinonasal lesion that originates from the mucosa of the maxillary sinus. Although antrochoanal polyps can occur at any age, they occur more frequently in children or young adults. In my present study, 61 cases were male and 39% were female. My findings were consistent with Cook et al. In the present series, 33.3% were 16 years old or younger.
Depending on the site of attachment within the maxillary sinus wall, in about 42% of the cases, the site of origin was not recognized. 26% originated from inferior wall, 14.2 originated from anterior wall, 9.5 from the lateral, and just 7.1 originated from the posterior wall. The main advantage of the present technique was to diminish the recurrence rate of antroconal polyps with minimal perioperative complications. A statistically significant decrease was seen from 19% with standard approach to 4.7% with new combined approach. To wrap up, an antroconal recognitive inflammatory lesion with high recurrence rate if not completely excised by removing the underlying mucosa at the site of origin. Therefore, the best surgical strategy should combine radical removal with low morbidity. Either the Cadwallac procedure or medial maxillectomy are effective in lesion removal, but it has higher morbidity. The strategy in the present study, namely combining middle meatal antrostomy with a minimal access through inferior meatus, showed a low rate of recurrence and low postoperative morbidity. These are my references, sir. Thank you.
What is your landmark to make an antrostomy in the inferior meatus in your cases?
Sir, after medializing inferior turbinate, the wall of the maxillary sinus, junction between the wall of the maxillary sinus and inferior meatus, there is a thin bone there. We usually do, sir.
See, you usually identify the inferior meatus by medializing, and when you pass the endoscope, inferior turbinate. When you pass the endoscope in that area, you can see the valve of Hasner.
Yes,
will you
sir.
do proximal or you will do distal to that area? Will you do before the opening of the valve of Hasner or beyond that opening?
Beyond that, sir.
No, you will do before. Okay, because you will be injuring the nasolacrimal duct opening. Okay, and here in your cases, which all patients you have chosen? How did you choose your patient that you will do? On what basis you will choose that you will do middle meatal antrostomy in one case or inferior meatal with combined approach in other case? What was your criteria to choose?
Sir, usually in children, as like in younger age group, as a maxillary sinus wall is not well pneumatized and alveolar process of the bone will be more prominent in children, I usually didn't prefer doing
Okay, that
inferior.
is agreed, but in your case series, of how many patients have you chosen case series?
42, sir, total.
Yeah. So how did you randomize? Did you randomize or you how did you decide that you will do which group and which group? Like whether you will do meatal antrostomy in one and combined approach in another. How did you decide? Who decided this?
Sir, randomly we did, sir.
Are all cases done by a single surgeon?
Yes, sir.
Okay, see, single surgeon studies are better because the differences in opinion will be
Yes, sir.
there. And what do you recommend? Doing inferior meatal window along with middle meatal antrostomy is a better outcome?
Yes, sir.
Okay.
The
See,
recurrence rates are
yeah. Recurrence rates are less.
less, sir.
Okay. See, also it will help you in checking in office by passing an endoscope in the inferior
Endoscope,
meatus.
sir. Yes, sir.
What are the common complications have you encountered by this method? Sometimes these inferior meatal window, what is the appropriate dimension?
Sir, like
Yeah.
no, we didn't encounter any complications, sir, except for anterior sinus in 2 cases, sir.
Okay. What is the appropriate size of the inferior meatal window? What is the diameter of your endoscope? 0 degrees.
4 mm, sir.
Yeah, almost little beyond that, so that you can pass your endoscope and an instrument.
True it, yes, sir.
Yeah. So which instrument you use to make a perforation in the inferior meatus?
Sir, Miles antronasal perforator, sir.
Any other instrument you can use? A simple straight Blakeslee forceps is also good enough.
Yes, sir. Wheels.
Right. Any other questions, sir?
No, sir.
Okay. Thank you.
Can I leave, sir?
Yeah, Dr. Ramya.
Thank you, sir.
Dr. Ramya, can you share your screen?
Yes, sir.
Rohit, is it the last one?
The last one, sir. Fazlur Rahman, he's not there. He's not responding.
Mark it as absent.
Yeah.
Good evening, everyone. My topic for paper presentation is
Please share
clinical
your
study of
window. I mean,
Sir.
Video.
Camera.
Your own video.
Is it visible, sir?
No. Start your video.
Yes, sir. Yes, sir.
Yeah.
Good evening, everyone. Sir, is it overlapping, sir? For you?
No. Continue.
Go ahead. Your time already started. Don't waste time.
My topic for paper presentation is clinical study of etiopathogenesis and management of facial nerve palsy. Facial nerve palsies are common and significant presentations specifically to otorhinolaryngologists. Facial nerve is a fundamental structure both for communication and emotion. It has a tortuous and long course through a bony canal known as fallopian canal within the temporal bone. So it is more prone to injury than other nerves. These palsies cause physical, functional, and psychological impact on the quality of life of the patient. So early evaluation and management is needed. Various causes of facial nerve palsy are idiopathic, temporal bone fractures, infections like otitis media, acute and chronic, tuberculosis, Ramsay-Hunt syndrome, malignant otitis externa, tumors, congenital and iatrogenic injuries. Applying anatomy to clinical history and examination, a clinician can identify the probable cause of facial nerve palsy and subsequently direct the management appropriately. Facial nerve palsy is diagnosed by its clinical presentation like facial weakness, loss of taste, decreased tear, and salivary secretion. Then otoscopic examination of external auditory canal, tympanic membrane is done, pure tone audiometry, and stapedial reflex is assessed. Topodiagnostic tests are done to find the site of infection. Radiological investigations like HRCT to know about the intratemporal segment of facial nerve, and electrophysiological testing in cases of trauma to know about the degree of dysfunction and chance of recovery. Among the cases of facial palsy, some patients improve after conservative management, but some need surgical intervention to relieve edema and to remove if any bone fragment is impinging on the nerve. The aim of the study is to study about the etiopathogenesis and management of facial nerve palsy. The objectives include to study the various factors responsible for the facial palsy, to analyze the outcomes of medical and surgical management policies adapted, to find out if early intervention can reduce the progression of the disease. The methods and materials included in the study are the study population consisted of only lower motor neuron facial palsy due to various etiologies attending or referred to ENT OPD. A total number of 15 cases are included. Detailed history taken, otological examination done, and palsy is graded according to House and Brackman grading system. Required investigations done, including audiometry and CT temporal bones. Surgery done to whom it is indicated, and others are managed conservatively, followed up at 2 weeks, 1 month, first month, third month, and sixth month, and their improvement is assessed clinically. The results of this study include gender-wise distribution showed slight male predominance. Age-wise distribution showed a predominance of 40 to 60 years age, followed by 21 to 40 years. Then causes, most of the causes were idiopathic, and level of injury. Most of the cases were found to be at the first genu level. And grading, most of the cases were around 12 cases from in 15 cases were grade 4. Medical management was done for 12 cases. 58% of these cases recovered, and among 2 cases which were surgically among 3 cases, 2 cases recovered, which were surgically managed. It is almost universally considered that Bell's palsy is idiopathic. So these major studies which did study on Bell's palsy showed that facial nerve palsy is mainly idiopathic. So this study also presented similar data, that is 40% of my cases with no specific causes are ruled as idiopathic. Viral etiology, which is due to herpes zoster, is seen in the in many cases. The Ryu and Lee studied that the prognosis of this syndrome is very poor. In Rafael and De Costa study, it showed that recovery is better if diagnosed early and treated early with antiviral and steroids. So in my study, 2 cases of herpes zoster are seen. One recovered completely due to the early treatment. These studies showed that cases of CSOM with cholesteatoma and longer duration of facial palsy showed poor prognosis than the cases with short duration of facial palsy and without cholesteatoma. In my study, 2 cases of CSOM, one with cholesteatoma and one without cholesteatoma, both recovered well. In this study, Karthik and Veena study showed that malignant otitis externa, medical management gives a better result. In my study, I had one patient of malignant otitis externa, but the recovery was incomplete after 6 months, even with anti-pseudomonal antibodies and strict glycemic control. In these studies, it showed that traumatic facial nerve palsies improve better if decompression is done within 14 days. So I had one case of traumatic facial nerve palsy, which was operated within 14 days, and it showed good recovery. In my study, there are 2 cases, 2 out of 3 cases of iatrogenic injury underwent surgery. One case showed early surgical intervention, and one more iatrogenic injury case, which was treated early with medical treatment, recovered to grade 1. So after consent, I'm providing these photographs, sir. So this is a case of CSOM with complete stenosis of external ear canal, which was treated with facial nerve decompression. After 6 months of treatment, it has recovered to grade 1. This is the decompression of that patient. This is a case of traumatic facial nerve palsy with longitudinal fracture of temporal bone. This is the decompression, and there was a bony fragment impinging on the nerve, which was removed. This is a case of medical treatment of facial nerve palsy, which is an iatrogenic facial nerve palsy during MRM. With medical treatment, it recovered well after 6 months. This is a case of herpes zoster infection. After 6 months, with early treatment and good management, it recovered completely to grade 1. These are my references, sir. Thank you.
Okay, just show your references slide. See, there is one slide, I think I just happened to notice it. Can you go to your presentation, please? 1 minute.
Yes, sir.
Yeah, go to the, there was one, next slide, please. Next. Next. Stop here. Previous. Yeah. I would request you to change your spelling It is Dr. Karthik Shamanna and Dr. Veena. Okay.
Okay,
They are
sir.
from
Okay.
Bangalore Medical
Thanks.
College. And
Yes.
okay, so that is something which I just noticed. Okay,
Yes.
this was changing trends in malignant otitis management.
Yes, sir. Thank you,
Right.
sir.
So images are all good. And the thing is, all your patients, you assess them by House-Brackman grading. Is there any other grading you know apart from House-Brackman grading?
Initially, I assessed only through House-Brackman's grading, sir. I know one grading which is about recovery, sir.
What is that?
Regeneration of facial nerve recovery grading, but I didn't take
There
it.
are no other classification of facial nerve apart from House-Brackman's.
There are there, sir. But
Can
I
you
did
name?
only.
Okay, fine. What are the topo diagnostic tests you know to assess for facial nerve injury?
Shimmer's test, sir.
Because I have not seen any being done in your case.
I presented only the initial and like after 6 months of management, sir.
Okay.
So there are
Sure.
Shimmer's test, stapedial reflex, gustatory, electrogustatory, and salivary flow test, sir.
Okay. Fine. Right. Thank you.
Okay. What is preventive ptosis?
Preventive ptosis, sir.
Hmm.
Like after facial nerve palsy, sir.
Hmm.
Applying a eye patch so that the patient
Okay.
and exercising.
You can use botulinum toxin.
Botulinum toxin.
Hmm.
Okay, sir.
Okay. Thank you.
Thank you, sir.
Yeah.
Any
Rohit?
more people left?
Yes, sir. Completed, sir.
Completed.
Okay.
Thank you, Rohit, and thank you, the judges.
Thank
Sir
you, sir.
Anil
Thank
Kumar,
you.
sir. Yeah. So every time you are helping our
Hey,
state branch, sir.
thank you, sir. Thank you.
Very grateful to you, and also Dinesh, sir. You
Thank
are
you, sir.
also given the guidance and instructions to our postgraduates in the yesterday session, and also acted as a judge for today's session. Thank you so much, sir.
Thank you for the opportunity, sir. Sir, now the marks I
Yeah,
have
accept
already.
those sent to my personal WhatsApp, so please kindly
Okay,
send to me.
fine.
So
Okay.
we will select the best 10 from each category, sir.
Okay.
So that we will avoid the clumsiness in the conference, physical conference hall, sir, so that they can attend all the other sessions.
Okay.
So these are all the sessions recorded very well, sir. They can go back to home and they can see how they presented, how will you ask the question. So it will be very good experience and rehearsal for their exams also, postgraduate exams also, sir. It's like a postgraduate exam, sir. Thank you so much for your presence in our virtual conference, sir.
Fine. Thank you.
Thank you, sir.
So since COVID, we are following this methodology for our postgraduate. Around 220 papers in all category we have received, sir. So
Oh,
that's
that
why
is
we are
huge.
yes, sir. So that we are taking the virtual session for each case report, case series, and e-poster also. I have sent to the judges, different set of judges from all over the South India, sir. they have shortlisted. After shortlisting, we are giving the opportunity in the physical conference, sir. So that they can attend more scientific sessions in the physical conference.
Okay. Very good. Very good. Will exit, sir.
Yeah, we'll call it a day, sir. Thank you.
Thank you very much. Thank you.
And
Thank you. One, two, three, four. One. Chico, you know today. 1, 2, 3, 4. 24 plus 7, 31. 1, 2, 3, 4. 28. 7 to 4, 28. 36.
Hello. Oh yeah.
Is other mama. I said mama. ఏది చెప్తున్నాడు అమ్మాయి అడుగుతున్నాడు నేను మర్చిపోయా అవును బాయ్ తీసుకెళ్ళిపోతారా పోలీస్ స్టేషన్ కాదు He's another ball. Four balls. నేను ఒకసారి హక్ చేసుకున్నాను ఒకసారి హక్ చేసి ఒకసారి ఓకే సార్ సరే కొంచెం చేసుకుంటారంటే ఈ బాబు తీసుకోగా మరి గుడ్ బాయ్ అన్నాడు అసలు అలా పెట్టాము గుడ్ బాయ్ గుడ్ స్మైల్ అబ్బా రావు చెందిన అదే కదా బాబా బాబా పడుతున్నాడు
Then you should show mask.
ఏంటి మీరు ఏంటి అలరి అన్న చూడండి ఎంత క్వైట్ గా ఉన్నాడు.
should be like Anand.
బావ నేనేం అన్ను బావ మళ్ళీ ఏం కవర్ చేస్తే అది డ్రెస్ లాగా ఉంది తెలుస్తుందంట. So I want to send that. Pero pasa la letra. Acabo de ver. Bien, ahorita saco de la. ఓకేనా డోర్ ఓపెన్ చేస్తే మాత్రం వెళ్ళిపోతాం చౌర్య అలా చేస్తే మాత్రం కావాల్సి వెళ్ళిపోతాం నువ్వు బాగా కంట్రోల్ చేయి
లోపల సెన్సార్స్ అవి ఉంటాయి బ్రెయిన్ అలా చెస్ట్ చెక్ చేయడం మెషిన్ అంటారు నీకు ఒకసారి చెక్ చేద్దాం నీ బ్రెయిన్ ఎలా పనిచేస్తుందో
అదేంటా
చేరు ముందు జరిగింది పడిపోతాం
ఇదే మా అమ్మకి ఇచ్చేస్తారు
మామ మీటింగ్ జరుగుతుంది
అదే మరి ఆగిపోయింది అదే చెప్తున్నాను నేను మంచిగా సర్జరీకి